Okay, I think we are live. So very good afternoon to everyone who's joining us on this lazy, warm, humid uh, afternoon. I'm Dr. Sandeep Sharma and I'm joined by an eminent panel of faculty members of DocTutorials. The NEET PG exam has just been held a few hours back, and we are here to not only give you the first insights, but also talk about how the exam actually went. What are the takeaways if you have given the exam? What are the takeaways if you have not done well? Where do we stand? And at the same time, what are the takeaways for those who will be sitting and targeting the next exams? Because every exam is a window, it is a peephole into how the exams are evolving, and evolution of exam also needs to be tackled. Immediately after this 20 minutes or 25 minutes of analysis and first review is done, we will immediately with the same video, please do not go anywhere, we will be moving over to subject wise recall. Very high quality recall will be done live by each faculty member one by one. So before I begin, let me directly move over to Rajiv Dhawan sir, your favorite ENT faculty. Sir was kind enough to take a break in the class. He's taking a class somewhere and talk about. Sir spent 15-20 minutes talking to students who in his group, and now sir is going to share his view about the exam. Rajiv sir, how was the exam and what
Sir,
is your feedback?
we were expecting little different style of paper because NEET PG 180 questions, 7 second extra per question. A lot of things we were expecting, video based question and everyone, but there was no video based question. And overall feeling of the paper is that it was moderate paper. It means cutoff is going to be higher. And if I can see the poll in the groups also, most of the people are saying it is moderate or towards the easier side. Very few people are saying it's very tough category paper. And image-based questions, they have come down actually this time because we know now it's like the ECG pattern. Priyash will say irregularly irregular, NB is also irregularly irregular. We don't know. We expect something and then something else happens, but that's what the surprise element always is there. So most of the people are saying that maximum question in which they could find some genuine images were between 20 to 30. So it was, you can say average 30 question were having some or the other images, close to that actually, but very few people said touching 40. And the long statement based questions, the majority group said that there were around 60 to 65 questions which were having four liners or more than four liners over there, which made the question reading a bit more challenging and fewer questions. But overall time management was not a problem for people if you take the whole block in account. And how many recent advances were asked? Most of the people said less than 5, maximum 10, but majority people said newer drugs, latest interventions, etc. They were very, 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 very negligible, maybe 6, 7, or not more than that. So no fancy drugs were there, no really major number, which actually sometimes the rank deciding category actually. So it was more general paper, and so it means that a lot of people will be getting a feeling that you will be actually getting a good score. But yes, in this kind of situation, negative marking will be the the rank deciding factor over there. So let's hope for the best. And last, before I conclude, the ENT part actually, if I can see whatever recall has come, was very much manageable. Ring care edema came with the picture again, and then thyroid surgery, nerve injury question. The patient is unable to sing a song, and exolaryngeal nerve injury. Carhart's notch again was asked with the image-based question. Trotter's method in epilepsy management, and cleft palate baby undergoing adenectomy, type of voice ranulalia aperta. I think those are very, 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 I was expected question over there. So please stick to this particular YouTube live because we will be coming out now for every subject. The respected faculty member is going to bring, what came over there, nearly almost similar, and we'll get a fair idea where we were actually. So let's hope really that we get a good rank. But my only suggestion to everyone will be, please now, next couple of days, just relax, roam around, just give yourself a little bit, because whatever result come accordingly will decide for the the future course. But you need to take break for few days. Thank you very much, Sandeep. Over to you.
Thank you, sir. So, takeaway from sir's point of view is ENT was solvable and paper was moderate level. Although the opinion, like whether it was moderate or easy or difficult, will vary according to an individual as well. So, another group of takeaways are the lot of ObGyn, lots of integrated questions in medicine and pharma, and lots of diphtheria in today's questions. Details, we will be moving over to Priyansh sir. Priyansh sir, you did, I think, appear in the exam also as a candidate. So, sir, you have a first-hand experience. Over to you.
Yes. Yes, good afternoon, everyone. And yes, Dhawan sir rightly said the paper was moderately difficult, not very difficult. If I have to give the segregation percentage wise, maybe we can say around 5 to 10 bounces, not more than that. Uh, uh, Tricky, or I would say the options were very close, somewhere around maybe 90 to 120 questions. There were there were around 20 questions which we can say very easy. The moment you will read that, the moment you will see the slide, you will get the answers instantly, multiple time asked. As far as image based questions were concerned, I would say somewhere near to 40 plus will be there. Maybe the image may not be required to solve the question in some questions, but there were images were there. Coming to time constraint, I don't feel that apart from one particular section, कहीं पे ऐसा time constraint जैसा नहीं लग रहा था, because there were lengthy questions, but at the same time in every section there were some questions which can be done in a very limited time. So that leverage was there and that we were using here and there. ऐसा कोई ऐसा पर्टिकुलर ब्लॉक नहीं था कि जिसमें बहुत ही सारे एक साथ लेंदी क्वेश्चन या बहुत खराब क्वेश्चन एक साथ डाल दिए हों. सब equally distributed था. So that was making the things easier. And as far as images were concerned, as they all were images which has been taught here and there commonly and taken from the internet, like ECG, PSVT image was there. And as far as biochem is concerned, around 8 9 questions were there. सारे आसान आसान से questions थे. Hyper ammonia, हर बार urea cycle disorder पूछा जा रहा है. Electron transport chain, arachidonic acid pathway. So there were not any bouncer as far as biochem is concerned, sir.
Sir, biochem was good. What about medicine, sir?
Medicine was integrated with pharmacology a lot. Diagnosis शायद एक या दो पूछे थे उन्होंने, बाकी कोई डायग्नोसिस नहीं था. हर जगह पे उन्होंने ये बोला था कि ऐसा ऐसा पेशेंट आया है. Say for example, aortic dissection का patient था, and then they said that what investigation you will do. They have not asked the diagnosis. In the same way, say beriberi का question दिया था. They have given the vitamin deficiencies and all. They said which test we are going to do. So हर जगह पे they have either asked the investigation or they asked the first line of management. Even in the surgery also, they have, and gynae also, they have not asked the diagnosis. They have asked what is the management or what is the next investigation you are going to do. So
Great.
for that, हमारे को मुझे ऐसा लगता है कि the approach towards the patient has to be understood while reading the topics. It's very critical now.
Absolutely, sir. I think
Conceptual.
the days of one-liners and only rapid revision or CPR or QRP, you have to read the concepts and build the concepts why a particular diagnosis is correct. Before we move to Nadeem sir, Priyansh sir, final word. What did you find difficult?
नहीं सर, मेरे को बिल्कुल नहीं आ रही थी. Actually it was not difficult, but मुझे नहीं आती. That is a difficult thing.
Very honest answer, sir. Thank you, sir, for your remarks. And you
Thank
have
you.
given the exam. I think you should get some food also.
Thank you,
क्योंकि
sir.
उन्हें
Thank you.
खिलाते नहीं
Yes.
हैं. We move
Thank
over to Nadeem sir. And before I let sir speak, sir, I'm jealous of the background behind you. What place you are in? Number one. Number
Right
two.
now,
How was the exam, sir?
right now I'm in Bihar. My center was in Bihar because I belong to Bihar. So as per
Okay.
Aadhaar card, they have given it.
Okay.
Yes, sir. Sir, exam I would say it was actually easy to moderate. I would say. हाँ, लेकिन बहुत सारे स्टूडेंट्स थे जो मैं वहाँ पे जब मैं सेंटर पे गया, बहुत सारे स्टूडेंट्स अपने थे वहाँ पे, और वो सबसे मैं मिला भी एग्जामिनेशन के बाद. तो everyone had this kind of feeling कि सर actually मतलब almost similar to FMG last time. Like I would say कि sir 50% questions were moderate, 50% questions, and hardly 10 to 15 questions were very very difficult. like approximately 70% topics I would say कि sir repeated थे. Like even के surgery हो या anatomy, even के anatomy से sir जैसे ENT में recurrent laryngeal nerve, external जो laryngeal nerve के voice में changes आ रहा है, right? Even के sir knife in the posterior triangle of the neck, उसके बाद से patient is not able to comb the hair, right? तो कौन सा मसल, कौन सा nerve injury, right? तो बिल्कुल इसी तरह के क्वेश्चन सर बिल्कुल आई फेल कि 70 to 80% क्वेश्चंस पर रिपीटेड टॉपिक्स जो इवन के सर निसीरिया मेनिंजाइटिस रिलेटेड था, वो फ्रेडरेशन सिंड्रोम जो सर वो है जिसमें एड्रेनल कॉर्टेक्स का जो आता है सर उसमें तो वो क्वेश्चन था ये जिसको आप ये कहते हैं सर ये वाटर हाउस फ्रेडरेशन सिंड्रोम.
यस
सर वो क्वेश्चन सब जो साइकेट्री के आवट से कि सर 6 क्वेश्चंस थे बहुत इजी. सिर्फ एक ऐसा टॉपिक था जो कि रिलेटेड, जो कि बहुत आउटडेटेड, वो 10 years बैक एक बार पूछा था, उसके बाद आज पूछा धात सिंड्रोम जो उसमें रिलेटेड टू फॉरेंसिक. देयर वर 6 क्वेश्चंस बट इजी ओनली सर, डूएबल, राइट सर. Like related to anesthesia, I think approximately 2 or 4 questions were there. So overall, like NEET PG से जो इस बार का सर ये जो जाएगा ना वो ज्यादा जाएगा. एंड आई फील कि जो नेगेटिव मार्क है, जैसे बाकी सारे फैकल्टीज ने भी कहा, धवन सर ने, प्रियांश सर ने, कि जो नेगेटिव मार्किंग होगा इस बार जिन लोगों ने मिस्टेक किया है उसकी वजह से रैंक सबका नीचे जा सकता है. अदरवाइज आई वुड से कि दिस वाज अ गुड पेपर फॉर एवरीवन.
Awesome, sir. Awesome review. And simultaneously, I'm also getting feedbacks from my own groups and my students who have already appeared in exams before. What they are telling is this exam was slightly different from the previous NEET PG exam because there were lesser images, similar to what our
Yeah.
faculty members
Yes,
have also
yes.
said. Nadeem sir has also
Yes.
said. And secondly, now it is like topics asan hai, but the options are close. And
Somewhat
negative
close.
marking
Yeah.
makes a difference. You can easily rule out 2 options, but then you get
Yeah.
stuck in 2 options. So I think that's going to make a difference. Nadeem
Yes.
sir, was time management an issue, sir?
I think, sir, this was okay. Like only a few questions were there which were very, very lengthy. Like apart from those questions, I would say it was fine. Like even के जैसे Glasgow coma scale का सर क्वेश्चन था कि like after accident patient is वो जैसे पेन के बाद वो रिस्पॉन्ड करता है, वो समझ नहीं पा रहा है, बिल्कुल एकदम सिंपल सीधा डेड क्वेश्चंस भी थे. तो सर आई वुड से कि हार्डली 10 to 20 बहुत लेंथी थे, बाकी मतलब मैनेजेबल सर.
Awesome, sir. Awesome, sir. आपने भी एग्जाम दिया. Please take some rest, some
Thank you,
fluids,
thank you, sir.
and
Thank you, sir.
we'll
Okay,
catch up.
everyone.
We'll catch
Yes,
up.
sir.
For sir will be joining us for recall in some time. But
Sure, sir. Sure.
let's move over to the pathology
Sure.
queen, Dr.
Thank
Vandana
you.
Puri. Ma'am is here. Ma'am, how was pathology and what is your feedback across your groups?
So as said by everyone, the feedback, the major feedback that I got was reaching and excluding 2 options were easy, but 2 options were so close enough that you could answer those only if you know the concept and the exact logic behind it. So that is one thing which I got. Second, pathology is a lot of image heavy subject, but still images were less, description of images were more. So like phyllodes came in the exam, so they gave description of phyllodes. Like seminoma is always an image based question, but this time it was not image. They just gave you the CD markers and the description. So they asked you what it can be. So they were description. Second, I think there was a lot of blood banking which came. So there was Strali and Taco which came from the exam. So a lot of practical questions also they tried to add here. Then there were a lot of case-based questions. So they try to integrate most of the questions clinically so that you should be able to know the clinical finding and then join it with the lab finding and come to the final diagnosis. Stain, most of the time, always it's there. So this was one of the jinx question also that came. So it was pearl stain that came in the exam. Apart from that, there was von Willebrand deficiency which came. So von Willebrand deficiency also was clinically oriented. So they gave always I tell students BT or APTT bada hua hai, so there's no other answer except von Willebrand deficiency. So that came. That was also a jinx question which I had posted. So coming to the next one, so hepcidin was the question which was also a previous year INICT question. So if you have done your INICT PYT well, you would be able to do these NEET PG also. So there was a hepcidin which was from INICT last time. Then there was onion skinning question which came. This was also one of the jinx question that I had posted. So apart from that, there were also questions on the students that said that there was tricky questions also, like they gave you lung cancer, synaptophysin positive, high NC ratio, high mitotic activity, whether it is a large cell carcinoma or small cell carcinoma. So that was a tricky thing. So there's something which is missing there. I'm asking students, what's missing? What's missing? Said, ma'am, itna hi tha, itna hi tha. So there has to be something which, helps you to reach the answer. Then there was advanced paternal age, which is associated with autosomal dominant or aneuploidies. So people confused it. Some of them marked aneuploidy. So it is autosomal dominant like that. So there was also, a CSF, which they gave, TB meningitis, which they gave. So basically, I would like to say that this was, I would not say it as an easy paper. I would say it as a tricky paper. And it was different from past year NEET PG question. They have tried to, bring an INICT pattern into NEET PG. And two options, they will help you reach till two options. After two options, it's only your concepts that are going to decide the answer. Apart from that, I would say there were a lot of tricky questions also, like HELP syndrome, schistocytes, and all that. So it was moderate level paper. And like everybody is saying, negative marking is going to play a role. So even though you will think that, okay, I've done my lot of answers, I've marked everything, but negative marking is going to decide your ranks.
Absolutely. From what we expect from a paper like this is, whenever the exam seems to be relatively easy, the problem comes because options are too close, and one change in the wording or one change in the, some value given can absolutely change the answer. So students need to be careful when they are, calculating their score according to recall. Second thing, there is going to be a lot of clustering. So be mentally prepared for that. What will be the cutoff? Obviously, we have to wait for the exact recalls to come in so that we can say better. Third thing, uh, you might be tempted to think, those who will be taking the exam later, ki sir, maximum was OBGyn medicine, so we should focus on OBGyn medicine. Yes, you should focus on OBGyn medicine. But in a paper in which there is so much of clustering going to be, every subject is going to matter. And some of the students have said, dermatology was slightly
Hmm.
more this year compared to other years of NEET PG. So we have the dermatology faculty of DocTutorials, Dr. Pallavi with us. The ma'am is going to tell you how dermatology was, what's ma'am's opinion, and what ma'am's group students are saying. Ma'am, over to you.
Hello, sir. Hello, everyone. I hope your paper went well. I have been told in exactly these words that dermatology was easy peasy. Though the questions were from the topics that are often repeated, but the framing of the questions was such that they appeared as if they are recalls, but they were not really recalls. That's what they are doing to most of the questions. They are rephrasing them in such a way that only doing a rapid revision or a PYQ based approach in your future exams is not going to help you, because you think that the question is familiar, you have seen this question, but a change in word here or there completely changes the answers. So that is something that you have to take care of when you are preparing for the future. For all those who are preparing, dermatology was relatively easy, quite expected questions, though I've not received any recall on STDs. That is strange, because normally we do have 2 to 3 questions on STDs every year, every exam, but this time the questions were on fungal infections. Then there was a question on pityriasis versicolor, erythema chronicum migrans, leprosy, vitiligo universalis, pustular psoriasis, a child with fever, sore throat, develops pustules on the body. What's the diagnosis? So these are all very expected questions, very normal to ask them. The questions were also not as close in dermatology. I would say it was relatively a straightforward paper. Then there was a question on Bessett's also, where there was a recurrent painful ulcers on the oral and the genital mucosa, and that was there as an image based question. Not as many images, but what came was easy. So I hope you all got the questions correct. And as everyone has said, it was more of a management based approach to the clinical scenarios that was asked. So you have to focus not just on reading the disease, but also understand the management, including what investigations and what treatment you would be doing in a patient, when and why. So that why part is what you have to focus upon for your future preparation, because that is what the questions want you to know. That is what will make you better prepared for your future exams. So that's it from me. It's all what everyone has already talked. I wish you all the best for
Thank you.
your results.
Thank you so much, ma'am. So I would be summarizing it like this. Paper was moderate. Some people found it easy. These are the people who have done their concepts well, have read textbooks sometime, and they know how to relate. But if you have only done one-liner kind of thing, or too much of uh, tabulated approach based thing, then you might have found it difficult. Because I'll give an example. I've been told that there was a question where a triangular facies was given, some description was given. Everyone could make out it is Bartter syndrome, but they were not asking Bartter syndrome. They were asking the site where Bartter syndrome is affected. Now, this is not pure pediatrics. You have to know, you have to go into the physiology part and know that ascending limb of loop of Henle is the site of pathology. So unless if your physiology is weak, you will not be able to reach the correct answer. If your pediatrics is weak, you would never know this is Bartter syndrome, and so your physiology concept will go waste. So you have to read every subject. And so my gut feeling, I will slightly put it differently. It was looking like a moderate paper, but there is going to be a lot of clustering. And yes, the questions which will decide your rank, they were tough. I would say it was a moderately tough, going against the tide. And some of my uh, friends and colleagues over there, it was moderately tough, not easy to moderate. It was moderate
So
to tough,
when
somewhere around that.
So when there is so much clustering, we would see that there are thousands of ranks within 2, 3 marks here and there. So yes, when there is a tie, your negative marking, your positives, how many correct you marked, all these things will come into play to decide your rank. So that is going to be a major factor.
Two types of queries are coming from the chat box. I'm also looking at them. One is some of the students are saying, sir, we have appeared in FMG before. How was this paper different from FMG? You cannot compare the two because FMG does not have negative marking. Here, the topics are different, and negative marking creates all that uncertainty in your mind. Secondly, quality wise, as I said, integration was the key, and there was a lot of pharmacology which was integrated with medicine and other subject. Direct pharma was limited, so if you are reading pharmacology, change the way you are preparing, do it in an integrated way. And today recall will be done where our esteemed faculty of pharmacology, Dr. Nilesh, will be coming, and he'll be telling you what were the answers, how to read pharmacology, and why, if you had gone through the pharma of DocTutorials, you would not have sweated a lot, because pharma is moving away from remembering those mnemonics. Mnemonics would have failed in this exam. I'm repeating, if you are basing your preparation on mnemonics, you are going to flunk unless and until you have a very good luck, or you have done some occult practices, some tantra mantra and all, or God is very, very kind upon you. Apart from that, you need concepts for cracking an exam like this. Any last words, Vandana and
So
So
Pallavi,
this
ma'am?
is
yeah,
something
so
I remember, ma'am, aap bolo.
no, it's okay. Speak.
Ma'am, this is something I remember from the last year's discussion, also First Insights, when we did that all the rapid revisions and one-liners and tables would not be of much use for the NEET PG paper. So this is exact discussion that was done last year also during the NEET PG 25 recall. And it is something similar we are talking today also. So that is where the exam is moving, that's where it is evolving, and we have to evolve in our reading and understanding according to what the demands of the paper are.
So yes, so basically that is, I think there is a major drift in the paper, and it has been drifting, I would say. Basically, it's more towards concepts now. I'll just give you a very classical example. So it was an X-linked recessive pedigree. So they typically asked you who will be affected, mother's father's or father's brother or mother's brother. So there was the options like that. Only until you know what is X-linked recessive, how it travels down the stream, you would not mark this answer correctly. So they want you to know your concepts. They know that there is so much information, mnemonics available in the market with AI so rampant in today's time. They know that people remember mnemonics. They don't want you to remember mnemonics. They want you to apply your logics because you are better than AI, right? So they want you to apply your brains. That is how the paper is moving. They don't want they don't want you to remember the old just mnemonic wise. They want you to apply your logic कि क्या diagnosis हो सकता है, मुझे क्या treatment करना है. So that's where we are going, and that's why the concepts are very, very important.
So to put it, put an end to this session, I would just say that this was a moderately tough exam. Some of the areas like pharmacology and OBG were on the tougher side. Close options, exam is drifting. Change your way of preparation. Those who will be appearing in the future exam, please understand that the examiner who are making your exam, they are not sitting at Mars. They are very much around us. They have the same Instagram, friends as you and me or others. They know what are being taught. They know the milestones, the mnemonics, the culture media, which are being taught as one-liners. This is time for you to evolve. Direct questions from a coaching center material, except if it is a very easy question, are not going to come. And this is going to be the pattern in the coming years. Thoda hard work, thoda smart work, lot of MCQ practice and integrate. That's the key for the future exam. And we will not waste any time. Thank you so much, Vandana ma'am and Pallavi ma'am, for your kindful insights. We will be moving over to the recall. So very shortly, anesthesia recall, we will be starting. Dr. Swati will be taking over one by one. Don't go anywhere, one by one. Each faculty member will come. They will discuss their recall based upon the best possible questions that they got, and you can actually see what did you mark and did you mark it correctly or not. So thank you so much, Pallavi ma'am.
Thank
Thank
you,
you for your
sir.
time.
Thank you, sir.
You can message me in the chat box. Hi everyone. I hope you had a good paper. This is Dr. Swati. So for anesthesia, I received very simple to very simple questions. Maybe you can add more questions. So the first question which I received was on regional anesthesia. A patient is planned for knee replacement surgery under spinal. Which of the following is an absolute contraindication of spinal? So the question is absolute contraindication of spinal anesthesia. So we talked about the 6 absolute contraindication. Let's see what are the options which has been provided. Previous spinal surgery. Now this is not an absolute contraindication. So this is not an answer. Uh, Hypovolemia. If patient is having severe hypovolemia, that is hypovolemic shock, it's an absolute contraindication because in spinal anesthesia, we cause something called sympathectomy. And because of this sympathectomy, more vasodilatation and hypovolemia can get exaggerated. So this is the answer. Third option was controlled hypertension. Now, controlled hypertension is again not an absolute contraindication. It is not a absolute contraindication. So got it? So this is the answer would be hypovolemia for the first question. The second question which I got, again, a very simple question. During an operative procedure, an intravenous opioid is preferred because it has an ultra short plasma half-life and rapid offset of action. So always in my classes, I talked about switch on, switch off drug. And which of the following is the best choice? So which is switch on and switch off drug? Switch on and switch off drug. The answer is remifentanil. So remifentanil is switch on, switch off drug because it is metabolized by non-specific esterase. So we have to give an infusion, and when we stop it, it is completely out of the body. So these are the 2 questions which I got for anesthesia. If you want to add anything, you are most welcome. I hope all my students must have answered these 2 questions. Thank you so much.
Hello, my dear students. Let me talk about the reconstitution on forensic medicine and toxicology. I have got about 8 to 9. Now I'll show you a few slides, then we'll discuss later. Okay. Number one, a child is brought to the hospital after sexual assault with an alleged issue of anal sex. Ideally, his examination is done. You know very well. I told you about the lateral buttock traction test. The ideal position is knee chest position. You have to put the victim in a knee chest position and examine the person. It is one of the easy question. Number two, after an RTA, a patient is brought from roadside to hospital in an unconscious state. Surgeon can operate. This is also very easy question. You know very well. In as per section 30 of Bharatiya Nyaya Samhita, in case of an emergency situation where the patient cannot signify consent himself, the doctor can proceed with the treatment, even operation. So answer is he can operate even without consent. Number three, what is the minimum time of eruption and completion of the center of the center shown in the circle? Circle, what they showed is upper end of Allah. You know very well. At the elbow, all the oscillators that are fused at the age of 16 to 17 years. We just say 16, it may be range of 16 to 17. So now option number D. So it appears at the age of 9 years, means 9 to 10, and fuses at the age of 16 to 17. Whereas in case of radius, it appears at 5 to 6 years and fuses by 16 to 17 years. So answer is 9 to 10 and 16 to 17. Number four, a patient is brought after sustaining gunshot wound. On examination. There is an oval-shaped entry wound with abrasion color along with presence of tattooing and blackening. Blackening means smudging around the wound. There is no burning of skin and no singeing. Of course, strictly speaking, this is intermediate range, because in case of intermediate range, there is okay, I'm sorry. There is one small mistake here because 1 minute. There is presence of tattooing and smudging around the wound. Okay, I'm sorry. Okay, so you know very well, in case of intermediate range, you see only the tattooing, but whereas in case of near shot, you see the blackening plus tattooing. And in case of point blank, there will be burning of the skin as well as singeing of the hair. So here the answer is near shot. Because there is tattooing and blackening, it is near shot. Number five. In case of substantial fetal abnormalities, MTP can be performed after the approval by the state medical board, even at a gestation period of, you know very well, up to 20 weeks only in case of contraceptive failure. Then up to 24 weeks in case of incestual relationship or in case of rape, also things you know very well. But even after 24 weeks, MTP can be done in case of substantial fetal abnormalities which are diagnosed by the state medical board. I'm not very happy with this question because it is a bit ambiguous, but the best answer, as you know, is 26 weeks. Number six, a known case of substance abuse is brought to the emergency with respiratory depression, bradycardia, hypertension, and pinpoint people. You know the poisoning is morphine or opium. The cure for opium is nalox. Okay. These are 6 questions I prepared in a PPT. Meantime, some people said one picture is given where the ostomy center of the lower end of femur is present. In that case, the lower end of femur appears at the age of 9th month of intrauterine life. And in that case, the answer should be the fetus was viable and more than 36 weeks of gestation, because 9th month means 36th week. So answer is more than 36 weeks. Okay. After that, I received another question. A 45-year-old man has been working in a steel and alloy manufacturing factory for the past 15 years. He presents with progressive behavioral changes, irritability, tremors, and features of Parkinsonism. You know very well in case of mercury poisoning, there will be erethism. Erethism means it is a psychiatric, neuropsychiatric manifestation where you get insomnia, irritability, and inappropriate shyness. Meantime, there will be three types of tremor, as you know, the Danbury's tremors, the Hatter shakes or glass blower shakes, as well as concussive mercurialis. So here the answer is mercury. Mercury. At the same time, almost all the metals give rise to Parkinsonism-like symptoms, but most commonly it is seen in manganese poisoning. But here the expected answer is mercury. Okay. Then one more question. A tentative bolt to the emergency with the suspected poisoning. Before performing gastric lavage, gastric contents are aspirated and tested by placing silver nitrate impregnated filter paper over the mouth of a flask containing the sample. On heating, the filter paper turns black. You know very well. If you suspect aluminum phosphide poisoning, you should take a filter paper impregnated with silver nitrate and keep it in front of the mouth. Ask him to breathe, or you can treat with the gastric lavage fluid or even the ometers. Then, if it turns black, it is diagnostic of aluminum phosphide poisoning. Okay, aluminum phosphide poisoning. So, one more is a 42-year-old boy in a rural area presents with progressive bowing of both legs. He has no history of trauma. On examination, mottling and brownish discoloration of the teeth are noted as shown in the image. Image 1, bowing of both lower limbs. Image 2, mottled teeth. Which of the following? It is strictly speaking, it is not forensic medicine questions. Okay, that may be medicine question. That regarding about 8 to 9 questions in forensic medicine. I hope all of you have done very well. Wish you the best. Bye bye.
Okay, hi guys. So, how did you do your NEET PG exam? So, first thing first, the exam is over. Okay, so any recall, anybody saying anything cannot beat the stress that you had in your exam. The options were very close this time. The image based questions were less, and there was a lot of tricky options which were there. Obviously, recalls, when we are sitting on the other side of the table, recalls appear easy, but it was not so in the exam. So, yes, guys, with that, just see the answers with a pinch of salt, because there might be, some changes in the options. There might be, this is just a recall, so that there's no it might not resemble the exact paper. Okay, so with that, let's start for the first one. So this was a classical question that was given, in which there were flexna, intestinal rosette, white eye reflex, and they asked the genetic abnormality. So everybody know this is a retinoblastoma. The tricky thing that they asked was whether it is a gain of function or loss of function. So I've told you this all the time. Tumor suppressor genes are always lost. So there is always loss of function of RB gene. Okay, so there is always loss of function that you need to remember. Coming to the second question, so this was a classical triad that they gave you. So patient had recurrent painful oral ulcers, genital ulcerations, and it was given. So this was so classical. This is Behçet's disease. We typically tell you that triad. So that is very, very typical of oral and genital ulcers were given. This is Behçet's disease. It's a type of vasculitis. Okay. Again, this was another question which I never expected for a NEET PG exam. It was little different. So this patient had aplastic anemia with no stem cell transplantation. What will be the treatment? So this is a recent update on the American Society of Hematology, which states that whenever a person has no hematopoietic stem cell transplantation, triple therapy should be given. That is, you should give ATG plus cyclosporin plus L-trombopag. So it's a triple therapy that you should give whenever the person does not have any hematopoietic stem cell donor or transplantation. So that is what you need to give. Okay, look at the next question. So this was also a jinx question that I had posted in the PDF and one day before on the Instagram also. I hope you saw it, and I have told this all the time. Whenever they give you this, that the bleeding time in APTT is prolonged, then always the answer is von Willebrand disease. Why did student got confused? Student said that ma'am factor 8 level bhi kam tha. So hoga hi na, I have told this all the time. Von Willebrand carries and protects factor 8. Okay, so if von Willebrand is not there, factor 8 level will be degraded. So I tell all the time to my students, von Willebrand deficiency is also called as pseudo hemophilia, because factor 8 carry karne wala hi nahi hai, to factor 8 level automatically will go down. Apart from that, there was a very classical history they gave you. Ristocytin aggregation was abnormal. So you don't need anything else. The answer has to be von Willebrand disease. Okay. Coming to the next one, this was again a repeat question. It's a repeat NEET PG question. Antimitochondrial antibody is seen in, you know this, it is a primary biliary cholangitis. It's a repeat question, has been asked many times before. So I don't think anybody did this wrong. Coming to the next question. So this was a patient with lung cancer. Uric acid was elevated. There was tumor lysis syndrome. What is a drug to reduce uric acid? So once the patient has developed tumor lysis syndrome, you have to save the child. That's very, very important. And in this case, you have to give rasburicase, because this is the time you have to save the patient. So rasburicase should be given. So to prevent tumor lysis syndrome, you can give allopurinol. But when you have patient has developed tumor lysis syndrome, rasburicase should be given. Okay. Again, I had given you one day before the crystals that can develop in tumor lysis syndrome. It's uric acid crystals. Okay. Okay, so look at this. This is a very classical question. Again, this is a simple question of X-linked recessive disorder. And they said that the mother is unaffected, obviously, because this is an X-linked recessive disorder. Which family member is most likely to be affected? So it's always the case that you have to remember that something, when the mother is not affected, okay, and the son is affected, who will be affected? So actually, the brother of the mother will be affected. So that's a very classical teaching. I've already told you. So father will never give the disease to the son in X-linked diseases. Okay. Mother is a carrier, so she gives the disease to the sons. Okay. And the daughters become carriers. So who will be the carrier? Who will be the carrier here? If mother is the carrier, her brother has to be deceased. Okay, so this is something which is another way of identifying who is the obligate carrier. Okay, so that is beyond your scope for now. Just remember, whenever it's an X-linked recessive disease, who will be affected? Mother's brother. It was also very important that it's an X-linked disease, so father has nothing to do with it. X-linked recessive disease, so father has nothing to do with it. Father and sisters, nothing has to do with it. It has to be mother's brother. Okay, now look at this. This was also a jinx question that I posted yesterday on the Instagram. I hope all of you saw that. This same image. This was nothing but Pearl's Prussian blue, and they typically ask you that the liver has coarse brown pigment. Which stain will identify this? This is very classical Pearl's Prussian blue. I hope everybody did this question correctly. Okay, look at this. So this is again a repeatedly asked question and a simple question. This is a tall person with arachnodactyly, ectopic lentis, chest pain. What is the pathology? It has to be defect in fibrillin. Okay, so that is one thing which was classical. It's Marfan syndrome, and it is FBN1 gene which is defective. And we keep teaching this again and again. So this was an easy question. Look at this. This was again a question which I had posted as a jinx so many times. I told you the story of men also. I hope you remember this. So this was Pan per Pith. Okay, so this was Pan per Pith, which I told you there was a boy who was very, very pyara, and his name was Pan Pith. Okay, so pyara Pan Pith. So this is pancreatic lesion and pituitary lesions was there, and this is pyara bacha. This is very classical men one. Okay, so this is very classical men one. Okay, and whenever we talk about men1, which chromosome is when men1 located? It is 11q13. Okay, it's present on 11q13. So that's very classical of men1, and that was the option. Medullary carcinoma is men2. I told you when you go to the medical school, then you become men2. Okay, so that is men2. So that's out. Red gene is most commonly mutated in men2. So answer has to be chromosome 11. So chromosome 11 is involved in this case. Okay. Look at this. So the patient has hereditary hemochromatosis due to HFE gene mutation, and there is increased iron absorption and iron overload. Which combination correctly describes this? So this is the mechanism that you always remember. So there is a gate, okay, in the intestinal cell. This is called ferroportin. Who controls ferroportin? Hepcidin controls ferroportin. So if hepcidin is low, nobody will stop or block ferroportin, and iron will be absorbed from the intestine into the blood. So if the hepcidin levels are low, ferroportin will be high, more iron will be absorbed from the intestinal cells, and more iron will be released into the blood. Okay, so I think this is intestinal cells which was given here. Okay, so this is just a recall I told. So it's not, it might not be the exact option. Okay, so that is very classical. So hepcidin is low, then ferroportin is high, and then iron is absorbed. Okay, absorbed from the intestinal cells into the blood. Okay, now this was a question on immunity, and again this was one question which we had discussed few days back. Okay, so what was the question? Question was that a tumor cell has no MHC1. So whenever the tumor cell has no MHC1, okay, so no MHC1, what will happen? They still, how do they escape immunity? So you have to understand this, that every whenever all the self cells, okay, all the self cells have MHC1, and whenever they have MHC1, then they can present the antigen to CD8 cells, and then only the CD8 cells can kill them. So what do tumor cells do? Tumor cells stop expressing MHC1. So when the tumor cells do not have MHC1, then CD8 cannot recognize them, and that is how they escape immunity. So that is how antigen presentation is made defective by the tumor cells. So tumor cells, when they don't have MHC1, they will not be able to present antigen properly, and that is how they escape immunity. So that was the answer in this case. All the other options were not at all fitting into anything. Okay, let's look at this. So this was a question which came from NEGM. Okay, so the classical question. So this was so that is why I always keep posting a lot of cases and images from NEGM, because these are very important classical questions that can directly come in exam. So this was very typical child that was given, and there was an infiltrate of cells with grooves or kidney shaped nucleus, and I had also given you a list in the PDF yesterday of all the cells with grooves. I hope you saw that, and that LCH was also there. So there was a typical CD marker which I told you, and this was also one of the question, the CD marker that I told you. CD1A and S100 is very, very classical, and whenever you have this is LCH. Okay, so Langerhans histiocytosis. And I hope most of you did this correctly as you were telling me. Good. Okay, now this was onion skinning, again one of the jinx question that I had posted. So onion skinning is seen, I've told you this so many times, it is seen in 3 lesions which you should always remember. Number 1, malignant hypertension. Malignant hypertension is also called as hyperplastic arteriosclerosis because the media shows hyperplasia. So in malignant hypertension, which is also called hyperplastic arteriosclerosis, then it is also seen in Castleman disease, which is also an important question that is always asked, in which the germinal center becomes smaller and there is onion skinning, okay, of the mantle zone cells, okay. And then it is also seen in primary sclerosing cholangitis, which is also a question which comes all the time, in which there is a bile duct in the center and there is sclerosis all around. So these 3 conditions keep on coming repeatedly in the exam and you should never ever forget it, okay. Coming to the next one, a patient has congestive heart failure, it undergoes autopsy, the lungs are firm, brown red. Which of the following findings are most likely observed in the lung? Okay, so this is a classical case of CVC lung that they are giving in the left heart failure. So definitely it has to be, the septa has to be thickened and filled with hemosiderin laden macrophages. So that's very classical of CVC lung. Looking at the next one, a patient with long-standing GERD presents diagnosed with Barrett esophagus. Histological examination shows different phases of columnar metaplasia, which is associated with the highest risk of progression. Obviously, we've told Barrett's esophagus. They're basically asking you Barrett esophagus. Which of the following describes Barrett esophagus? You already know goblet cells. You should just search for goblet cells. So there is intestinal epithelium with goblet cells. It is Barrett esophagus and it has highest chances of developing adenocarcinoma. Look at this. This is a history that they gave. Okay, so this is still unsolved tricky question. Okay, so they typically gave the hemoglobin is low, the platelet count is also low, the AST and ALT is within normal limit, fever is there, and altered sensorium is there. And they gave schistocytes also in the option. Okay, so whenever you have schistocytes with altered sensorium, okay, irrespective of anything else, okay, and if fever is also there, okay, so that is supportive. This is nothing but TTP. And whenever we are looking at TTP, majority of the TTP are immune TTP. So what you need to do? You need to do plasmapheresis to remove the antibodies and FFP to give ADAM-TS so that, you know, von Willebrand can be cut and all that thrombus that is formed can be cut. Okay. So that is why you have to give FFP with plasmapheresis. Okay. So plasmapheresis is the answer here, and FFP will give ADAM-TS, which will go and cut ultra long von Willebrand factor. And once the von Willebrand factor is cut down, automatically the thrombus will break. So that is very typical. So that was TTP. There was also a question of HUS, which students told me that there was a classical history of diarrhea given and then there were schistocytes. So yes, so it might also be there. Okay, so there was another question on HUS also, but I didn't get the exact recall, so I've not added it here. Look at this. So this is a couple who went for preconception genetic counseling. Mother told about the potential risks with advancing age. The counselor explained that increased paternal age is associated with increased risk of genetic disorder. So this I just posted on my Instagram after the exam, obviously after you told me. So whenever we have increased paternal age, you have to remember increased paternal age is typically associated. Mother told about the potential. Okay. 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 So, yes. So that is autosomal. So I think instead of mitochondrial disorders, they gave you aneuploidy. Okay. So that was an option in this. Aneuploidies are usually associated with increased maternal age. Okay. Whereas increased paternal ages are usually associated with your autosomal dominant disorders. Okay. Right. Okay, let's come to the next one. Okay, so look at this. So this was a classical question. I hope everybody agrees to that. So this is a patient with progressive dyspnea, pan-acinar emphysema was there, and there was PAS positive diastase resistant globules, which enzyme deficiency is there. So emphysema with the liver disease. Okay, and pass positive diastase resistant globules, we have discussed this so many times. This is alpha 1 antitrypsin deficiency. So that's a classical case of alpha 1 antitrypsin deficiency that you need to remember. Coming to the next one, so they typically gave you testicular mass. So there was less image based questions there here this time. So what did they give you? They typically gave you these CD markers. They typically told you that these tumor cells were positive for CD117 and OCT34. Even though there was such a large description that was given, but you can easily come to the CD markers here. OCT34, CD117 with testicular mass. There has to be no other answer except seminoma. So it has to be seminoma. Look at this again, the same. They didn't give the image of phyllodes this time. They just gave you the leaf like pattern. Okay, so please remember, so leaf like pattern, it was not phyllodes here given, just leaf like pattern was given with increased stromal cellularity and stromal atypia. So whenever there is increased stromal cellularity, stromal atypia, leaf like pattern, it has to be phyllodes tumor. So it has to be phyllodes tumor. Okay, look at the next one. Whenever the patient, now this is very tricky question. Okay, so I am not sure, because students are saying that they had not given centrally located hilar mass. Okay, so this was not given in the option. That is what they told. Okay, so they gave you smoker. They gave you, I don't know, they didn't even give you small blue cells. I think they just gave you rounded blue cells. Okay, hyperchromatic nuclei was mentioned. High NC ratio was mentioned. Nuclear molding was mentioned. Mitotic activity was mentioned. And area of necrosis was mentioned. Synaptophysin positivity was mentioned. What is the diagnosis? So students were confused between small cell carcinoma and large cell carcinoma, which you have to remember. So remember, why is it small cell carcinoma and why not large cell carcinoma? Because large cell carcinoma will have large cell with prominent nucleoli. So if they give you prominent nucleoli, okay, then you should think of large cell carcinoma. Or if they give you gynecomastia as a paraneoplastic manifestation, then it is large cell carcinoma. So but this description which is given here, molding giving hyperchromatic nuclei, has to be small cell carcinoma. Okay, yes. Coming to the next one, look at this. This is again a pregnant female. Within 6 hours she developed acute dyspnea, respiratory distress. Chest x-ray shows you bilateral opacities with pulmonary edema. There is no evidence of left-sided failure or circulatory overload. I don't know this was given in the exam or not, but what is the catch point? You have to look for JVP. If JVP is elevated, then it goes to TACO. But I think JVP elevation was not given. Okay, so there is no JVP elevation and packed red cell transfusion was given with opacity, then it fits into TRALI. So if they give you blood pressure increase, JVP increase, then you should think of TACO, but that was not given in the option. So if this was not given in the option, it rules out TACO. So therefore the answer here will be TRALI. Okay. Now, this was another question that was very typically given here. So, this was a 9-year-old boy presents with the cola color urine hypertension 2 weeks after the typical streptococcal infection. There was red cell cast in the urine, and they show you hypercellular glomeruli. Some students even told that there was neutrophil infiltration that was given. So, what is it most likely? So, this image of a hypercellular glomeruli, whenever they give you, you don't have any doubt, it has to be PSGN. Okay, so it has to be PSGN. Yes, Atau, you're right, Rahman, perfect. It is 3 hours. So many students said this also. It is within 3 hours that they develop transfusion. So okay, so that is correct. Okay, so answer doesn't change with that. Within 6 hours is usually TRALI. So this is PSGN, which you should be very clear again. Okay, so that's all, guys. So these were the questions that I could get from pathology. There are more. We would happy to share. You can please share it with me, whatever you know more. And if I missed any, please let me know. This is what I got from students. So I hope this helped. Yes, all the very best, guys. And take a break, take a rest, and all the very best.
asking you how was your exams. So the chat box is also open. Yeah. If you have any comments about the exam, please do write in the chat box. Asking you how was your exams. The chat box. So from what I understand after speaking to most of my students is that it was a moderate exam. And we did not have many questions from orthopedics as such. So I have collected a total of 4 questions. These questions are basically the recall questions. And if there is any change in the structure of the questions or if there are any changes in the options, please do let me know. Yeah. So I'll start with the first ortho question. A young man presents with foot pain after road traffic accident. X-ray is given below. What is the diagnosis? So this was one question that many students were confused among 2 options, whether this was Lisfranc fracture or Jones fracture. So from what I understand, this was the kind of X-ray. What do you think? This was the X-ray that was given for you, right? There was an injury in this area near the tarso-metatarsal joint. See in the foot, the tarso-metatarsal joint. See, these are the tarsal bones and these are your metatarsal bones and this is your tarso-metatarsal joint. And this joint has its own name, which is Lisfranc joint. Lisfranc joint, okay. So any fracture or dislocation occurring in that area is called Lisfranc fracture dislocation. So this X-ray is that of Lisfranc fracture. If it was Jones fracture is a fracture of the base of the 5th metatarsal. So the fracture would be somewhere here. So Lisfranc fracture is very, very important because it can be very subtle and you can miss it. And if you miss it, then the patient can have a lot of misalignment in the joints and the patient will find it very difficult to walk. So the answer here is Lisfranc fracture. Yeah. Next MCQ is this. A 5-year-old child is brought to the emergency department after being suddenly lifted by the hand while playing. Since then, the child refuses to use the affected upper limb and keeps the elbow as shown below. What is the most likely diagnosis? So what do you see in the image there? What is the position of the limb there? The limb is in pronation, isn't it? The forearm is in pronation. And this is a clear-cut indicative of which condition? It is your pulled elbow. Pulled elbow, okay? And what is pulled elbow? Pulled elbow is nothing but a minor subluxation of the radial head out of the annular ligament. So the answer to this question is pulled elbow, which is basically radial head subluxation. Yeah. Third MCQ is this. A 16-year-old male presents with pain in the lower limb. His CT is given below. What is the diagnosis? Can you look at the CT and tell me what the diagnosis is? See, this structure that you see here is the physis or the growth plate. And this is your epiphysis and this is the metaphysis. And from here down would be your diaphysis. And in the diaphysis of the bone, you can see a small clear area, isn't it? There is a small clear area. This is what we call as a nidus. This is called as nidus, which is surrounded by all this white stuff. What is this white stuff? This is what we call as sclerotic bone. Sclerotic bone. So there is a central area of lysis, which is called nidus, surrounded by sclerotic bone. Can you imagine something like this? There is a O and it is surrounded by another O. So there are 2 O's. So the diagnosis is osteoid osteoma. So the diagnosis is osteoid osteoma. And few of my students told me that the question was regarding the treatment. Yeah. So the question was regarding the treatment. If it was treatment, then the correct answer would be radiofrequency ablation. Radiofrequency ablation is the treatment of choice for osteoid osteoma. Okay. So that is the answer here. Yeah. Next question. A 26-year-old man presents with persistent wrist pain after a fall on an outstretched hand. The AP and lateral wrist radiographs are shown below. What is the most likely diagnosis? So if you look at the X-ray here, can you tell me what is the classical sign? This is something that we learn every time, both in radiology and in orthopedics. See, what is this? This is the X-ray of wrist, AP view. And this bone that you see here is your scaphoid and this is your lunate. And there is a visible gap between the scaphoid and lunate. And this is what we call as the Terry-Thomas sign, isn't it? This is called the Terry-Thomas sign. And Terry Thomas was a American comedian, isn't it? He was a Hollywood comedian and he had a big gap between his front tooth. That is why this X-ray finding is called Terry Thomas sign, and it is classical of which condition? Scapholunate dissociation. Scapholunate dissociation. So that is the correct answer here. Okay. So Manoj is saying that in osteoid there was a lot of soft tissue inflammation in the X-ray. Skin inflammation is also extensive and it resembled cloaca. Okay. So if there was a clear-cut cloaca and everything, then probably it would have been an osteomyelitis, but that would be chronic osteomyelitis. Was chronic osteomyelitis in the option? Was chronic osteomyelitis there in the option? Okay, same. All right, then cloaca and everything is a feature of chronic osteomyelitis and not acute osteomyelitis, right? So these were the 4 questions that I was able to get. Another question that many students told me was about a elbow X-ray of a child, and the question was to assess the age of the child. So I do not have the exact X-ray with me, so I'll just give you the clues as to how to approach such a question. Okay, so how to assess the age based on elbow X-ray of a child. So basically there is a very easy mnemonic, CRITO. These are the 6 main ossification centers that you encounter in a child. C is for capitulum, R is for radial head, I is for internal. Internal is basically your medial epicondyle, T is for trochlea, O is for olecranon, and E is for external, which is your lateral epicondyle. Okay, external epicondyle. So capitulum ossifies by 2 years, radial head by 4, internal epicondyle by 6 years, trochlea by 8 years, and olecranon by 10 years, and external or lateral epicondyle by 12 years. Okay, so you can just count the number of ossification centers. Let's say there are 3 ossification centers, then the age of the child would be at least 6 years. If there are 5 ossification centers, then it would be at least 10 years. Okay, so that is how you approach a question of a child's elbow X-ray, and a question on age is asked. Okay. All right. So I think there were only 5 such questions in orthopedics. I would say that orthopedics was a little moderate paper. There were 1 or 2 questions that were normally not asked probably in the last 5 years. But overall, if you had learned the topic, I think you would have been able to answer everything. Only one point I have to tell you is that now the exam is over. There is no need to stress about it now. So you might have made a little bit of silly mistakes here and there. It doesn't matter. Everyone makes those mistakes. Don't worry. Take rest. You have studied very hard, and whatever rest you are taking now is hard earned. Okay. So don't worry. When the results come, we'll see. Okay. So all the very best. And if you have any doubts, you can reach out to me or to DocTutorials for any help. All right. Bye.
Yes, everyone. Very good evening to all of you. So, okay, so NEET PG, overall NEET PG exam is done, right? So, like in total, 6 questions were there related to psychiatry. I would say out of 6, 5 questions were 100% easy, very, very easy to solve. Let's see all the question one by one. First question. See here, this is actually this question which I'm asking you, this is rarely asked question, right? So this is related to culture bound syndrome, which I've taught you during the class. Like a 25-year-old patient from a rural area visited a primary healthcare physician with complaints of restlessness, low energy, fatigue, black discoloration below the eye, anxiousness, after that irritation. And after that, what he feels that reason for these symptoms is loss of semen due to habit of frequent masturbation and wet dreaming. Sometimes he feels that whitish discharge is also there in his urine. Which culture bound syndrome this depicts? I already have taught you like about these two. One was the Koro syndrome. Second was the Dhat syndrome. What I have taught you? Like suppose if a young boy is there, he is getting anxious because of, like suppose if he's very, very slim and trim, he's feeling what? I'm becoming weak because of, because of loss of either semen into urine, or even I'm losing my blood in the, like in the semen. So this is a case of actually Dhat syndrome. Dhat syndrome is the answer. But what about the Koro syndrome? See, a kind of belief that one day there can be a retraction of penis back into abdomen and I will die. So here answer is Dhat syndrome. Second question, a 25-year-old young man is socially withdrawn since his childhood. He gives cold response to social cues. He exhibits some odd and inappropriate behavior and holds some peculiar beliefs. Which personality trait he has? We have learned as per DSM-5 that personality disorder can be divided into cluster A, cluster B, cluster C. Like in cluster A, we have learned about paranoid, schizoid, and schizotypal. See, where a person is doing like everything is odd behavior, odd speech, odd dressing, like believing in magical thinking. If there will be so much of a stress, patient can develop delusion and hallucination also, right? See here, so these people are very superstitious. Yes, schizotypal. But remember here, as per a new classification, what I have taught you, that there is one update in ICD-11, right? Schizotypal, this is no more considered as a personality disorder. Now it is considered as at the borderline of schizophrenia. But here, as per the situation, personality trait, answer will be schizotypal. See, what about schizoid? Schizoid means like when a person is emotionally cold and socially detached, right? I hope all these points are clear to everyone now. But what about this question? Can you answer me now, all of you? See here, after a major elective surgery of total hip replacement, a 73-year-old man is found to be mentally confused on post-operative day 2. He was completely lucid on day 1. See, he tries to pull out his IV line also. He shows loss of concentration during conversation. Now, they have asked which of the following is the most suitable bedside test modality for this patient. Here, answer will be CAM. This is called the confusion assessment method. Basically, this is actually, this is a standard test, right now, which we are using in a patient of if there will be acute delirium, if there will be acute, like if there will be acute onset of, like mental confusion, right? Very easy to understand here. So now, see, there are 4 features. There are 4 features of, remember here, there are 4 features of CAM, right? This is called the confusion, remember, assessment method, right? First, acute onset. After that, lack of attention, inattention, lack of attention. And then there will be disorganized thinking. And then there will be altered level of the consciousness. So here answer will be CAM. Next. Yeah, this question, this is actually, I would say this was actually a direct question. A known case of substance abuse is brought to emergency with the respiratory depression, bradycardia, hypotension, pinpoint pupil. We have learned about overdose of opioid. There will be CPR. Patient will be in coma. After that, pinpoint pupil. Then a respiratory depression. Because of respiratory depression, after that, what will happen to the patient? Low BP, low heart rate, hypothermia. Yes. So overdose of opioid. What is the antidote? IV naloxone, where we have learned like this is very short acting drug. Half life will be only 30 minutes. Only 30 minutes. Naltrexone, where do we use actually naltrexone? Yes, this is used for relapse prevention. Relapse prevention in opioid overtoxicity. Easy to understand here now. Relapse prevention. Yes. Next question now. Yeah, this question, I would say, this was actually a difficult question. Actually, a difficult question. First of all, let's learn here. A 34-year-old patient, a known case of psychosis, was taking clozapine for last 6 months. As per history, he stopped smoking for last 4 weeks. Okay, he stopped smoking. Basically, now here examiner wants to ask like a kind of interaction between smoking and clozapine. Okay, smoking and clozapine. So I would say this was a type of difficult question. He complains of 2 episodes of seizure in last 5 days. What can be the reason for seizure? First of all, let's understand here. See here, this was actually like here, like this option you can improve. Like option number 4, like increases. Okay, increases. Okay, now, see here, please understand here. First of all, when I talk about smoking, please remember it. This is like full of concept, this question. First of all, please understand, like smoking will induce. See, smoking will induce. See by, say yes, SIP1A2. First of all, please understand here, smoking will induce SIP1A2. Okay. Remember here, because of this now, say because of this now the clozapine level, see now the clozapine level will be decreasing in blood, Okay, chalo, this much point is clear to everyone now. Okay, fine. Now, see, okay, when a person is going to stop smoking, now what patient is going to have now? This is the point here. Because of this, now there will be no induction to SIP1A2 here, right now. See here, now this will be actually inhibited, right? Now, so because of this, what will happen here? Now there will be abrupt like increase of clozapine in blood. Now there will be increase, means I would say okay, now there will be increased level of clozapine level, right? If dose will not be adjusted. This one point is clear to everyone. So now you can understand here that what are the grave side effects, what clozapine can do when there will be like excess of the clozapine will be there in blood. Yes. So this can lead to seizure. Now. So here answer will be 3. Here answer will be 3. Okay, fine. So this was full of concept. Relation between smoking and clozapine. All right. Now, next question. A 24-year-old bipolar male patient was taking lithium 900 milligram per day and quetiapine 50 milligram per day. He started having the tremors, dysarthria, and ataxia. There will be no exam without a question from lithium toxicity. Right now, lithium will be damaging different organs. So in CNS, this can lead to coarse tremors. After that, there can be dysarthria, there can be ataxia. Like what about the endocrine? Yes, this can be leading to disturbances in what? The TSH hormone. So this can lead to hypothyroidism. See, in GIT, this can lead to nausea, vomiting. Like in a renal toxicity, this can lead to polyuria. After that, polydipsia. Finally, diabetes insipidus. Over the skin, there can be folliculitis. There can be red rashes. And in the first trimester of pregnancy, this can lead to Obstein's anomaly, right? So here, answer will be lithium toxicity. Lithium toxicity, right? All right. Fine. So we have completed all 6 questions. I hope you people have done good job in psychiatry. So I wish you all the best. Thank you so much.
Before starting, how was the exam? From majority of the students, the impression I got was it was moderate, and some were saying even easy as such, moderate. But one thing that was common, which every student told regarding ObGyn was questions were in abundance. It was lengthy questions. It was often so lengthy that students were having a bit of difficulty even recalling the questions properly. So I will be taking your help as well, so as to recall few of the points which is related to the questions also. But we had a fair share of questions in ObGyn. We are in that very nascent stage where we are still collecting questions. But yes, as we would be adding more and more points to it, we'll have a final recall. This is the initial nascent stage of those questions, which is there. We'll be discussing those things, and we'll do a proper final recall as well. Yes, OBG dominated more, gynecology dominated more than obstetrics too. True, Riyarmi. Yes, it was there. It was abundant number of questions. Gynae was there. But something which was very peculiar that I saw was even that cancers did not get that much dominance this time. Usually we have a fair share of questions from cervical cancer, the screening, which is always an expected question. Those questions were not there much predominantly this time as such. Even endometrial cancer, yes, endometrial hyperplasia related questions were there, but not that endometrial cancer, ovarian cancer. All those cancers did not dominate the exam, this exam, as compared to the previous exams as such. Yes, mostly the topics which were asked were familiar topics, those topics that we see in OPD, we see in labor room. It was not something which was completely unknown. More of those familiar topics were there, but with a slight twist, unfamiliar twist, some tricky options. And students were telling this very frequently that questions dekha rega lag raha hai. It seems familiar, but the options were a bit confusing. If you really learn only, you can differentiate between those options which is there. This time we got long stem clinical questions. No video-based questions was there. No video-based questions at all. AUBS, abnormal uterine bleeding, was highlight. Even the students were telling fistula. There was fair share of questions from fistula, fibroid. Some areas were heavily dominated as such in this paper. They asked always this management next line rather than one-liner kind of questions, which was there. They gave this good clinical scenario STEM-based questions, and they were asking, what will you do next? How will you manage the patient? What will you do for the patient? Such kind of questions. Even we got a fair share of image-based questions like fibroid, adenomyosis was given. Even fibroid, that Figo classification has been asked in it. This molar pregnancy image-based question was there. So fair share of image-based questions also was there. And no video-based questions, no maneuvers were asked as such this time. Yes, 2 questions from VVF. Yes, yes, I got that feedback from the students. Yes, fair share of questions. Overall, how did you find ObGyn guide before we discuss the questions as such? How was ObGyn guide? Were you able to, like, from the feedback which I got, majority of the questions were doable. Yes, there was few bouncers, there were tough questions, but overall ObGyn guide did not feel like much of a bouncer kind of area. Students told that majority of them were doable as such. How did you all find the questions? Moderate? Easy? Too easy? All right, let's see. Let's discuss the questions one by one. First of all, so this question was from prolapse of uterus. An elderly female has come to you, 61-year-old female. She has come to you with prolapse. Key points here, they have specifically mentioned that she is not sexually active. She wants a minimal procedure and she has history of heart disease. See, normally speaking, in a 61-year-old female, the definitive management would be vaginal hysterectomy plus pelvic floor repair, that is ward Mayos hysterectomy. But the catch here is they are telling that she does not want a definitive procedure. She wants a minimal procedure, and indirectly they are telling you that she is unfit for surgery. She has heart disease, all those things. In this scenario, the option that you can consider is Lee-Ford colpocesis. In Lee-Ford colpocesis, you basically approximate the walls of vagina, especially in very elderly females who's unfit for surgery, especially considering the fact that she is not sexually active. Do not do this procedure in a female who's sexually active. Your main thing, closing of the vagina. Okay, vagina ko band kar rahe ho. बहुत young patient में who's sexually active, do not do this. This is an ideal candidate in which you can go for this Lee-Ford colpocesis. Yes, did you mark the answer as Lee-Ford? Even in our CPR also, we had discussed this, all those one-liners in each of this scenario. What will you do? Young patient, family, completed family, not completed, old patient. Yes, patient who's unfit for surgery, what to do? Yes, this. Yes, exam was amazing. CPR was very helpful. Very glad to hear that. Yes. Yes, moving to the next question. Next question. In this, patient has come to you bleeding and she has already underwent a hysterectomy, and the gross image shows that there is an intramural fibroid. What non-surgical treatment could the patient have undergone instead? Any points you want to add to it, feel free to add the extra points. Like if you are able to recollect the age of the patient, parity which was given in the question, that will be really helpful. Assuming that she has already underwent hysterectomy, I'm assuming that she's an elderly female in whom family is already completed, and for that she underwent this hysterectomy. And they are asking you, instead of the surgical measure, what else could you have done for this patient as such? What are the other medical measures that you can do for the patient? You can give these patients initially for the bleeding tranexamic acid can be tried, OC pills can be given, but especially in elderly, we don't prefer that. Often we resort to levonorgestrel intrauterine system, that is Mirena. If the patient asks you, will Mirena reduce the size of fibroid? No, not really. It will only help in symptomatic management of abnormal uterine bleeding. It will not help to reduce the size of fibroid as such. Drugs that can reduce the size of fibroid include your GnRH agonist, GnRH antagonist, which is there. Even mifepristone has a role. Danazol has some role. We don't prefer this danazol. Why am I not choosing danazol among the option? Because it has androgenic side effects. Androgenic side effects. Among the options, I would say the better answer is levonorgestrel containing intrauterine system, because other options are not applicable. Estrogen therapy is not given for these patients. Estrogen, as you know, hyperestrogenic state is a risk factor for fibroid. We don't give estrogen for management of this condition as such. Again, copper containing IUCD does not have any role in treatment of fibroid. Among the options which is provided right here with me right now, my answer would be levonorgestrel containing intrauterine system, that is is Mirena, which will help to tackle the abnormal uterine bleeding for the patient. Not only that, progesterone also helps to prevent endometrial hyperplasia and endometrial cancer as well. So that's an added benefit that you get. Helps to control the menstruation. It helps to prevent these changes from happening. Yes, so correct answer is C. All right, let's move to the next question. So there was an image-based question which was given about middle cerebral artery, and they had given that middle cerebral artery MCA PSV, peak systolic velocity, is more than 1.5 MOM. Yes, so what's the meaning of this more than 1.5 MOM? Initially, as you know, any patient who's RH negative, ICT positive, next thing that we will do is ICT titer. If ICT titer is more than or equal to critical titer, next we proceed with MCA PSV. This middle cerebral peak systolic velocity, middle cerebral artery peak systolic velocity will help you to assess for fetal anemia. And if you see that MCA PSV is more than or equal to 1.5 MOM, it is suggestive of anemia. It is suggestive of anemia. It is suggestive of anemia. Yes. Is it mild anemia or moderate to severe anemia? It's pointing towards moderate to severe anemia as such. So yes, the answer is it is pointing towards anemia in the fetus. Once MCA PSV is more than 1.5 MOM, there is no point of still following up the patient with this middle cerebral artery Doppler. You are going to next proceed with chordosynthesis followed by IUT. You will take the blood from the umbilical cord, check for the hematocrit. If you find that baby has anemia, immediately you will proceed with intrauterine transfusion. Yes, question had more than, okay, we are getting more details of this question. Question had 1.64 MOM, all right. And it was given that week was 28 weeks. 28 weeks, all the more reason at this early period of gestation before term, patient has this condition, you are going to detect fetal anemia, you are going to proceed with chordosynthesis, take out the blood, check for hematocrit and proceed with IUT if there is anemia. Yes. They were focusing much on fibroid today. Yes, I heard that AUB, fibroid, all those topics, and also fistula. I saw a funny post from somewhere that probably the examiner is suffering from this fibroid fistula, something like that. That's why they are focusing so much on this. I like just a post which I saw in Insta today as such. So yes, there were some areas which were heavily focused as such in this exam. That is true. Yes, fibroid, all those things. Yes, chordosynthesis was one of the options. So, Haribala, can you please clarify? Did they ask what is the interpretation, or did they ask what will you do next for the patient? Was the question about interpretation or asking you what will you do next for the patient? If they had asked, or was it two different questions like that? If they ask you the interpretations, yes. If they ask you the interpretation, your answer is moderate to severe anemia. If they ask you what will you do next for the patient, next I will prepare for chordosynthesis followed by IUT for the patient. Intrauterine transfusion has to be done for the patient. Okay. So Haribala, can you give me more clarity on what exactly was there? Was they asking the interpretation or what to do next in the scenario? Interpretation was asked. Thank you, Grace. Thank you for that. Interpretation means your answer is simple. Your answer is going to be moderate to severe anemia. If they ask you what to do next for the patient, you're going to next proceed with chordosynthesis followed by IUT. All right. Is it okay? Anything else you want to add in this? Can we move to the next question? Interpretation was given. ICT was also provided. ICT was 1:64. Yes, ICT was also given. See, anytime ICT is more than or equal to 1:16, that is taken as critical titer. There is higher risk of anemia. ICT more than or equal to 1:16. ICT more than or equal to 1:16, which is critical titer. What will you do next for the patient? You will proceed with middle cerebral artery peak systolic velocity. MCA PSV more than or equal to 1.5 MOM, suggestive of fetal anemia. After that, you are going to proceed with chordosynthesis followed by IUT, intrauterine transfusion. Okay, let's proceed to the next question. Yes. In this question, a patient has come to you at 38 weeks of gestation. She has well-controlled GDM on MNT, medical nutritional therapy. Bishop score is 4. What is the management of this patient? See, what do we discuss in the sessions regarding induction of a patient who has GDM, who is well-controlled on diet? someone who is GDM, who is well controlled on diet, there is no need to deliver them early. You can proceed from 39 to as high as 40 weeks and 6 days. That is up till 41 weeks tak hum ja sakte hain. If there is no need to deliver them early, you can proceed till 39 to even 40 weeks and 6 days also. That is till 41 weeks tak to ja sakte ho. The patient is currently only 38 weeks. Even if the bishop score is 7, I understand it's a favorable bishop. Yes, bishop score more than 6 is taken as favorable bishop. Just because it is favorable, there is no need to immediately go and induce the patient. What can you do for this patient? You can wait and induce the patient at 39 weeks. Yes, 39 weeks. In this scenario, was rupture of membrane there? I don't think so, dear. I think the rupture of membrane scenario was another question where the patient has come with mild bleeding. Yes, all those things was there. That is the rupture of labor, the rupture of membrane related question. As far as I got, can someone again please confirm? Was rupture of membrane given in this question? Or was it in that bleeding related question? Patient has come with bleeding, rupture of membrane since 24 hours. Yes, patient has requested induction was there. Just because patient has patient has requested for it, you need not directly go for induction. You will counsel the patient about risks, benefits. You can still wait for induction till 39 weeks. Just look at the other options. They are not telling that induction as the patient is requesting. Other option is induction because she is diabetic. Being a diabetic patient, GDM who is well controlled on diet, there is no need to induce the patient less than 39 weeks. You can wait minimum till 39 weeks. Proceed with injection as bishop score is already more than 6. Again, it's not an indication as such. If that option of 39 weeks is there, that would be the best answer. Okay, yes. Rupture of membrane was not there in the question. This was a routine antenatal patient who has come. Okay, so routine antenatal patient, this is what you're going to do. GDM who's well controlled on diet, proceed with induction around 39 to 41, 40 plus 6 weeks that you can wait for this patient. That is up till 41 weeks, yes. No need to directly go for induction in this scenario. Next question, this is a direct question as such from ectopic pregnancy. What is the indication for surgical intervention in ectopic pregnancy? We always discuss this. When do you give the medical management? Medical management is given when the patient is stable, the size of ectopic should be less than 4 centimeters, HCG should be less than 5,000, cardiac activity should be absent. If there is presence of fetal cardiac activity, that is an indication for surgical management. Did all of you get it right? Yes. Another question, where methotrexate, it's not completely clear. Yes, let me just turn the screen so that I can read it completely. Yes, another question where membrane was ruptured. Yes, I got it here. Another question where membrane is ruptured. We will discuss that, Haribala. Soon we'll discuss that. Cardiac activity present. Okay, this was the option. Yes, I hope all of you mentioned this answer. That is fetal cardiac activity is present. Fetal heartbeat, which is same as cardiac activity present. This was a simple direct question as such. All right, moving to the next question. There was a palm coin classification from that question. They had given a gross image, histopathology image was given, and they had asked what is actually this palm coin, whenever they are giving a gross specimen, it's either palm, it's only palm, polyp, adenomyosis, leiomyoma, or the malignancy as such. What are you appreciating over here? This is again a repeat previous year question. Slightly they have reframed in palm coin, that is all. What we are seeing over here is a diffusely enlarged globular uterus, uniformly enlarged globular uterus. This is pointing towards adenomyosis. Adenomyosis. Yes, this is pointing towards adenomyosis. If I write it in palm coin, I'll write it as AUBA. AUBA. Yes, palm coin classification. Sometimes even we write like this P0A1 kind of representation also. No polyp, adenomyosis is there, no leioma, L0, M0 kind of thing. This is AUB, abnormal uterine bleeding, which is caused due to adenomyosis. Again, this was a direct question which came. These are those questions which directly fetches you mark. Your explanation was playing in the exam for the ectopic. I marked fetal cardiac activity without second thought. Thank you so much, dear. Yes, so happy you directly marked it. I hope even for this question of adenomyosis, you directly marked that answer, which is adenomyosis. Yes. One question on ECV and weight 3.5 kg. Yes, exactly. We'll come to that, Grace. I have that question with me. We'll come to that. two fibroids given, it's not the exact figure. Okay, dear. If that's not the exact figure, that's why I have provided the other images also. Just look at the image. I don't know what exactly you saw in the exam because I did not give the exam. See, if they give you this irregularly enlarged uterus with multiple well-defined circumscribed growth, what is your answer? This is fibroid. If you get an image where there is no circumscribed lesion, but the uterus as a whole is enlarged, diffusely enlarged globular uterus, please mark your answer as adenomyosis. Please mark your answer as adenomyosis. As far as confusion goes, these are the two images which you can get confused if at all it has not. Adenomyosis, diffusely enlarged uterus. If you see this discrete mass irregularly enlarged, mark your answer as fibroid. If it is endometrial cancer and all, usually you will see this growth which is coming from the endometrial cavity. Usually in case of polyp, you have this well-defined polypoidal lesion which is projecting towards the uterine cavity. Okay, so mark accordingly. Can you please confirm, was it adenomyosis which was given or was it fibroid? Adenomyosis or fibroid? I think we have supporters for both assets. Okay. A few of the students who messaged me, they had mentioned adenomyosis. If at all it was fibroid, there will be this irregularly enlarged group, which is there. Then mark your answer as fibroid. All right. Moving to the next question. Yes. This was another question, very similarly, patient with bleeding PV kind of question. Gross image post-hysterectomy image was given. Patient has presented with bleeding PV. What is the likely diagnosis? Actually depends on the image which is there. These are the options that I got. Endometrial cancer, leiomyoma, as well as adenomyosis, which is there. So yes, it depends on the exact image which you got. If it was a diffusely enlarged globular uterus, your answer is adenomyosis. If you get the uterus with these discrete swellings, that is fibroid. If you see the growth arising from the endometrial cavity, yes, it is endometrial cancer. Yes, what I got was, as there were two questions which was very similar, one from palm coin classification, one was an elderly female. Students were telling one image was really the adenomyosis image, which was the other was fibroid. Yes, adenomyosis picture was given. Yes, adenomyosis, endometrial hyperplasia was also in the option. Okay. So let me add the fourth option. You even had endometrial hyperplasia. Thickened endometrium. Endometrial hyperplasia was also in the option. All right. Okay, yes. Moving to the next question. This was again a direct question, I would say. They had shown an ultrasound. Ultrasound shows that snowstorm appearance, which is pointing towards molar pregnancy. They had asked regarding the post-evacuation management. After evacuation of a molar pregnancy, how do you follow up the patient? We follow up the patients with HCG. HCG assessment is done weekly for the patient. Initially, you will test after 48 hours. Then you will do it weekly till negative. And once it is negative, you will proceed for monthly assessment for 6 months. And during this time, it is very important that she will avoid pregnancy and contraception has to be given to these patients. So beta HCG has to be done weekly till negative, followed by monthly for 6 months. Until this time, contraception has to be given. Going to the other option, beta HCG, once every 2 weeks. That's not right. We do it weekly. Prophylactic methotrexate is not again indicated in a low risk patient who had this molar pregnancy evacuation. Okay, we are getting additional information from this. In this, even HCG was mentioned. HCG was 1.2 lakhs. Okay, 1,24,000 was the HCG. Yes. Palm coin, phagotype. Yes, phagotype was asked. Ma'am, diffusely enlarged hyperplasia or leiomyoma. If the uterus as such is diffusely enlarged here, that is your adenomyosis. Whereas if it is your endometrial cancer, yes, this uterus as a whole is enlarged. Endometrial cancer, you will see more thickening over here. The uterus will not have that globular shape. That is the main visual clue to differentiate between this. Yes. Did you all mark it right? HCG, which is done weekly, and also contraception has to be given till the follow-up is completed. All right. Moving to the next question. Yes. One of my students was mentioning this question in the middle also. This was the question which was based on external cephalic version. This was again an image-based question. They had shown images of external cephalic version and they asked, where is this procedure not done? When is it not done, guys? External cephalic version is done for transverse lie. We usually do it around 37 weeks. Even for complete breech, we try to turn the baby. Baby weight is less than 3.5 kg. There is no contraindication. You can absolutely do. We want an adequate size baby. Pelvis has to be adequate for the patient. The membrane should be intact. Light curve should be adequate. All these criteria, and there should be no contraindication for vaginal delivery. In those scenarios, we turn the baby around. Baby is already dead. There is fetal death. That's not an indication for proceeding with external cephalic version per se. Yes, in this correct answer is fetal death. Fetal death is not an indication for proceeding with ECD. We don't do in case of intrauterine death. Yes, so the answer to this is option C. Option C. Yes, moving to the next question. Okay. Which ligament is primarily responsible for maintaining anteverted position of the uterus? These were not the options. As far as I know, the options that you had included round ligament, uterosacral ligament, and two other options were there. Main thing I want to know is even cardinal ligament. Main query I want to know, was there an option which was a combination answer? Did they provide an option like this where round as well as uterosacral was given in the option? Can you please confirm? Mali, Ashish. Yes. Nature Lover Way, Swati, Grace. Yes. Can you please confirm? Yes. Was there a combination option present? Susham, Shusham is saying yes. Yes, there was a combination option. If there was a combination option, round and uterosacral, that's the best answer that you can choose. Anteversion as well as this maintaining the position anteversion is maintained by a combination of round ligament as well as uterosacral. Sometimes they don't give it as a combination. If at all you're made to choose maintaining anteversion, first answer is round ligament, next comes uterosacral. If they ask you what will prevent retroversion, your first answer is uterosacral, next answer is only round ligament. Is that clear, dear? If you had a combination answer, go for that. Clinically speaking, it is both round as well as uterosacral in a combined way helps to maintain the uterus in an anteverted position. But if the options are split, and if they ask you which will maintain anteversion, first answer is round, next comes uterosacral. If they ask you which will prevent retroversion, your first answer is uterosacrals, next answer is round ligament. Yes, this is how you're going to choose. I see yes for majority of the students says yes, a combination was there, that's the best. Okay, IP ligament was there in the option. IP does not have any role in this. Yes, infundibulopelvic ligament was there. You can safely rule it out. IP ligament mainly provides that ovarian artery and all supplying to the ovaries. Yes, thank you so much for contributing to the points as such. As I heard from majority, a combination answer was there. Please choose that combination answer. It's not cardinal. If at all they have given it as separately, your answer is first answer round, then only go for the answer uterosacral. Single best answer would be round. Moving to the next question, which was related to fistula. Patient has come to you with fistula. A 3 swab test is done, and it is showing that the swab, the upper swab is soaked, but there is not stained. Okay, soaked, not stained is the buzzword for you. It's a repeat question, nothing new here as such. Soaked, not stained. Tell me from where is this water or the stain, the fluid coming from? It is urine. Yes, it is fetal. It is the urine as such which is coming from the ureter. It is coming from ureter. When you do methylene blue dye testing, the dye will remain only within the bladder. So even if it is vesico-vaginal fistula, connection is from the vagina, connection is from the bladder to vagina or urethra to vagina, it will be stained. Whereas if the connection is between ureter and vagina, ureter does not have that staining of urine. It will have that clear urine color as such. So it will be, the main buzzword is the swab is soaked but not stained. Okay, soaked, not stained. This is buzzword for you. Blindly go and mark your answer as ureterovaginal fistula. Yes, ureterovaginal fistula. Of course, if there is ureterovaginal fistula, is normal urination possible or not? she can urinate. The other ureter will still fill the bladder and she will be able to urinate. In contrast to vesicovaginal fistula, all the urine is getting drained through the vagina. So she will not be able to self-urinate or self-void as well. Even was that point given in the question? Did they give that point that she was able to urinate by herself? Grace, you mentioned that point. Normal urination is possible. Did they give that in the question? Yes. She is able to self-void or self-urinate. Upper swab was mentioned. Okay, upper swab. Upper swab was mentioned. It is soaked, not stained. Yes. All right. Okay. So it's typical question of our ureterovaginal fistula. Next, students were telling me that Figo staging of fibroid has been asked. They gave an histopathology image as such. We don't know exactly what the histopathology is, but from what the students are recalling, majority are saying that there was a fibroid in which more than 50% of part was intramural, less than 50% was actually submucosal. Majority as such was intramural kind of thing. This is the complete Figo staging as such that we discuss. If you see that it is mainly submucosal. If you see that majority, more than 50% is intramural, it comes in Figo type 2. If at all that is the image. If you get an image where it is predominantly coming into the mucosa, little bit part only is there within the muscle, that would have been type 1. If it was completely pedunculated coming inside like this is type 0. If you see predominantly it is intramural, very little part is submucosal, this will come in type 2. If it was type 3 image, they will give you that there is a fibroid which is just touching the endometrium, So again, as it's a gross image, can you tell me what exactly they had given in the image? Was it just touching? Was it more than 50% within the muscle? Or less than 50% within the muscle? Maximum number of students whom I have asked this, they told that majority it was more than 50% within the muscle. So best answer I would choose right now is type 2. I don't know exactly what image had come, but this is your core concept. Remember this table, guys. Just look at how much percentage of fibroid is within the muscle or within the uterine cavity and answer accordingly. Ma'am, less than 50% in the myometrium. Okay, less than 50% is in myometrium. Now I'll like to change the answer. Less than 50% means if that was the image, that will be type 1. Yes, it depends on the image. More than 50%. Okay, both answers I'm getting. More than as well as less than, both. Within 2. More than 50% was within the muscle. Okay. More than 50% means that is type 2. Depends on the exact image that you got. They can give you any histopathology image from their surgical experience as such. Any uterine specimen can be given. It depends on exactly how much was there within muscle, outside muscle, within the uterine cavity. Yes, majority of the students who had told, many are telling that more than 50% was there. Okay, so in that situation, let's keep it as type 2. All right. Moving to the next question. This was another question where there was so much disparity as such, which I got from the question. A pregnant woman has come to you. There is mild blood stain discharge since past 24 hours. There is no active vaginal bleeding. The patient has baby in cephalic presentation. There is no pain. Why is this pain so significant? Bleeding with pain, if it was there, my first differential would have been abruption. Or even bleeding with pain, patient could be even in labor with this blood stains discharge being shown. So there is no pain. Patient is not having any bleeding at present. Another very important differential I'm thinking right now is it placenta previa kind of picture? Placenta previa, the ultrasound would have definitely told you that there is placenta previa. Students clearly mentioned that ultrasound was given, which was nearly normal. There was no mention of placenta previa. So it's not placenta previa, it's not abruption as such. They are giving you that membranes are ruptured, minimal blood stain kind of discharge. Even it could be the show which is initially forming in the patient. What will you do for the patient? Patient has been in this leaking or pre-labor rupture of membrane for the past 24 hours. Now, an important information I would like in this question is, what is the period of gestation? Can someone tell me, like, what was the period of gestation? Patient was stable. Even it was given that patient is stable. Good. Patient is stable. Ashish, Mali, Ritik, any of you guys remember the period of gestation? Was it less than 37 weeks or more than 37 weeks? Less than 34 weeks or more than 34 weeks? These are the important cutoffs that we need actually. Yes. If she was more than 37 weeks, vitals were normal, everything was normal, it was mentioned. Okay. If suppose she was 38 weeks, thank you so much. Yes, Mali. Shashank, thank you so much. Yes, no pain and everything. She was 38 weeks. Makes our management very easy. We are dealing with a case of PROM. What will you do? She is having leaking for beyond 18 hours. What will you do for the patient right now? You don't want chorioamnionitis set in. You are going to induce the patient. You are going to induce the patient. If the same scenario, I'm just making one modification. I'm changing this as ultrasound shows that there is placenta previa. Now, what would be your management? Ultrasound is not NAD, bleeding has settled. She is already beyond 37 weeks. She has placenta previa. Then my answer would have been cesarean section. But here, note guys, here the question is giving you ultrasound is normal, no evidence of placenta previa. In this scenario, I'm going to induce the patient. Correct answer here is induce the patient. Yes. Did you guys think in terms of that PPROM or PROM, or did you get caught in those placenta previa abruption related scenarios? Question had more than 37 weeks. Yes, majority are telling 38 and 39. Whatever, 38, 39, it does not matter. Anything beyond 37 weeks as such, patient has come to you with leaking. She has this leaking for more than 18 hours. In that scenario, you will proceed with induction of the patient. Yes. Not cesarean section, mainly because there is no indication for cesarean per se here. If she was a case of placenta previa, yes, then in that scenario, you could have chose this cesarean section. If there was fetal distress mentioned, again, you could have gone in favor of cesarean section. Is that clear, guys? Here, correct answer is induction of labor. Induction of labor. All right, moving to the next question. Which procedure gives the best outcome before IVF? Patient has come to you with hydrosalpinx. They are asking you which procedure has best outcome before this undergoing this IVF assets. Salpingectomy, salpingostomy, aspiration of this hydrosalpinx, which is the problem with hydrosalpinx is there is this fluid collection within the tube. This toxic fluid keeps on draining towards uterine cavity. It reduces the chance of implantation. It increases the chance of washout of these embryos, which is there. It is actually the environment inside the uterus becomes detrimental for the fetus or the growing embryo. That is why majority of the patients, I have a patient who has hydrosalpinx. She is planned for IVF. Usually the first procedure that we plan is cut out this connection between the tube and the uterus. Either you can do for clipping. You just apply clips so as to close this connection, or you can take away the whole tube itself. That is salpingectomy is done for the patient. No point of aspiration or salpingostomy. You're going to proceed with salpingectomy for the patient. Hydrosalpinx due to distal tube disease was mentioned. Okay, they had given the patient has hydrosalpinx along with distal tube disease. Okay, usually many times this happens whenever the patient has a distal block. For some reason, there is a distal block in the patient. The tubes get filled with this fluid as such. Again, we don't want this toxic fluid draining into the uterine cavity. You can take out the tube or put a clip over here. Either clipping can be done for the patient, or you can even proceed with salpingectomy. Distal tube affected was given. Anything else, any other information which was added? This is all we require to answer this. Salpingectomy is given, hydrosalpinx is given, they are giving distal tubal disease as such. In that scenario, before proceeding with IVF, you are going to train it. There is no point of aspirating. We don't go for aspiration again, it tends to fill up. Salpingostomy, we don't do salpingostomy here. Only indication for salpingostomy. What is salpingostomy? It's a tube preservation surgery where you put an incision, you take out the ectopic pregnancy, you leave it open. Only indication is if family is not complete and contralateral tube is affected in case of ectopic pregnancy. Yes, in case of it. Doxycycline will take care of it a bit, but it's not the definitive management. The best thing that you can do prior to IVF is proceeding with this clipping. Best would be clipping, and even salpingectomy could be taken up in that option. Yes, medicines can be given, doxycycline, all those measures, but usually hydrosalpinx is there. Then we proceed with this clipping for the patient. Best answer is clipping. That is what we clinically do. That's what's recommended in the guidelines as well. You go for clipping or salpingectomy. It gives the best outcome before IVF. Best outcome. Okay, options given: salpingectomy, proximal tube blocking, aspiration of the tube, and salpingostomy. Okay, this was the option, no doxycycline. All right, so it becomes much more easier for you to choose from the options as well. Answer is salpingectomy. All right. Moving further, I heard there was a question on medical termination of pregnancy. Patient has come to you beyond 24 weeks for medical termination of pregnancy. When will you do this medical termination of pregnancy? If the patient is less than 20 weeks, one registered medical practitioner is required. 20 to 24 weeks, two registered medical practitioner. Beyond 24 weeks, you can only do it after approval from medical board. After approval from medical board, which is constituted by gynecologist, radiologist, pediatrician, only if there is substantial fetal anomaly. There is substantial fetal anomaly. Only if there is substantial fetal anomaly. Okay, fetal anomaly was there in the option. Okay, so that's the answer. Beyond 24 weeks, you will go for this. If there is substantial fetal anomalies, then you can include this. Okay, after approval from the medical board, that is state medical board. Thank you so much for contributing the extra information, Medico. So I assume the question was, patient has come to you for MTP beyond 24 weeks. When will you do medical termination, or in which criteria will you do it? Beyond 24 weeks after approval from medical board, only if there is substantial fetal anomaly. MTP1. Yes. So that was the final question as such. Overall, this is what I feel about the exam. It's not a very tough exam per se, but yes, the options have been tricky. They have taken full effort to confuse the students because they gave such lengthy questions. Even students were like, ma'am, there are many questions which came, but I'm unable to recollect the exact options or exact wordings which is there. So they did a good job in giving you very lengthy questions, but I hope at the same time you are able to overcome that and do excellently well in the exam. So I know at this point of time, we have all those regrets, questions, doubts running in the mind. But at this point of time, I just want you to leave all those things. Take a deep breath. You did your part, guys. You did it beautifully well, I would say. Just trust the work that you have done. Take a break. Okay, after recall, everything is over. Even you can skip the recall part also, no problem. Just after this is over, go relax, chill with your friends, spend some time with your family, see a movie. Yes, all these things will pass. Whatever effort you have put in will definitely pay off assets. Yes, all the very best. And definitely, as we get more and more points, you can feel free to message me also. My Instagram ID is OBG with OBG_Gayathri. Any extra points, any extra questions, feel free to send it to me as well. So we'll come with final recall after I get all the points from all the students once you're all settled down. Yes. Thank you so much. All right. Yes. One question on OHSS as well. Okay. If possible, do share that to me also. I did not get that question. Mother also had the same history in OHSS. Okay. All right. Do send me the question if possible. I also, in the meantime, I also try to collect it. Chorioamnionitis question was given. Chorioamnionitis question, Sai, was it the same question which we were discussing, the leaking related question? Management. The patient has come to you with ruptured membrane, slight bleeding for the past 24 hours. That might be the very similar question. If at all they had given direct chorioamnionitis situation also, you will deliver as early as possible. You will induce the patient. You will give her antibiotics, plan for delivery of the patient. Yes, with that, let's conclude our session, I would say, waiting for the next faculty to join in. So all the very best, guys. Take care. Have some well-deserved rest at this point of time. Loss or gain of mutation in OHSS. Okay, yes. Okay, yes.
And I am a happy educator because I got to know that ophthalmology was pretty easy. And actually, somebody wrote that, ma'am, ophthalmology was the only easy subject which came in the exam. Was it like that? So, as we have asked a lot of they were like of the opinion that exam was moderate, not very easy, not very tough, but the exam was doable. The questions were actually good, doable. Now, if we talk about ophthalmology, I could only gather 8 questions. Okay, 8 is little less for NEET PG, but I want you to help me to finding out more questions so that we can frame a proper paper for you. And let's start with ophthalmology. We had a lot of clinical questions also, a lot of picture-based questions also. So let's start with the first one. It says a patient came with this picture on slit lamp. The picture was given where you had a lot of keratic precipitates, and the special part about the picture was there were stellate keratic precipitates. Stellate means you have dispersed kind of precipitates. Usually we have KPs which are settled down on the back of the corneal endothelium, but this time they were stellate KPs. And a very easy question it was given. There was a hint of Amsler sign positive. So what is the most likely answer? It is very simple, Fuchs. And I've told you multiple times, bar मैंने पूछा था, you will get something on Fuchs. You will get something on Fuchs. So I am sure my students were able to answer this question easily. है ना? I'm not discussing the other options as of now, but you should know all the other options as well. Okay, if this was the question, Fuchs heterochromic iridocyclitis was very, very easy. We know there is a heterochromia. We know it's a mild grade uveitis and there is a bleeding on paracentesis. So this sign is your Amsler sign. It was a very straightforward question. Okay. Now let's talk about question number 2. This is one thing which is, little difficult if we talk about the options because we had very close options. So let's go with the question. It says that the patient presented with acute onset redness, watering, and some people say that there is a follicular reaction also. And surely there was a lymphadenopathy. Lymphadenopathy to tha. Okay. And some people are also saying that there is a pharyngitis as well. So I'm not sure whether pharyngitis was there or not, but definitely it was a picture of conjunctivitis, which also show a hemorrhage. So probably it's a hemorrhagic kind of conjunctivitis with a lymphadenopathy. Okay. I could gather the information that this was at least present in the question. Okay, so lymphadenopathy, redness, watering, and a hemorrhagic kind of conjunctivitis. Like if this was a picture given, if this is an image based question, it shows there are a lot of hemorrhages here. Now, if this is the question, I would say enterovirus is the best answer, though adenovirus is very, very close. Okay, we have spoken about PACE viruses. Adenovirus and entero both are there to cause hemorrhagic type of conjunctivitis. But when we talk about the most common one, it has to be enterovirus. That is why the best answer is this. But some people are saying that there was no mention of hemorrhage here. It was not hemorrhagic conjunctivitis. It was only a conjunctivitis which says follicular conjunctival reaction. So if this is a follicular conjunctival reaction with a lot of spread lymphadenopathy, this has to be adenovirus. Okay, so I want to have a proper question here. If you can help me with that, please write down in the comment sections what exactly was the question. I've told you about both the things. Okay, rest of the options were not important. Adenovirus and antero, we have the confusion between these two. Now guys, again, I would say this is a lovely question, a wonderful question. Please see. It says a patient of anterior uveitis is found to have posterior synechiae. Okay, posterior synechiae are common in a case of anterior uveitis. Now, what is the most appropriate drug to break the synechiae? Now, suppose if this is the question. Okay, suppose if this is the question, then definitely atropine is the answer. But there was a twist in the question. Probably some students are saying that the mention was, what is the most appropriate drug with a miotic agent? Okay, with a miotic agent. So first of all, I would say this is a weird question. Why are we giving miotic in a case of uveitis? Because miotics like pilocarpine, they are also pro-inflammatory. So why would I give a miotic? Now guys, it's an old school of thought. Please understand this question. If you are giving a miotic and if you want to add something to dilate the pupil just only to break the synechiae, as the question is asking, what is the drug to break the synechiae? Then guys, the better answer will be phenylephrine. Why? Please remember, if we are giving atropine we do give in the initial period, we have to give atropine because it will break the ciliary muscle spasm, it will relax the ciliary muscle, it will release the pain. है ना, ये तो देना ही है, atropine तो देना ही है. But what about only to break the synechiae? If you want to break the adhesions, है ना, and we are giving meiotic also. So guys, what is the funda here? The funda here is we want to give a short acting mydriatic agent. We want the pupil to remain mobile. है ना, अगर atropine देंगे तो what will happen? The pupil will keep on dilating. It will remain dilated for 3 weeks. So don't you think in a dilated pupil, the synechiae can also form? है ना? So please remember, if they are not mentioning about meiotic agent, the best answer is definitely atropine, isn't it? We give atropine in the initial 2 weeks so that there is a ciliary muscle spasm breakdown and your pain is gone. But if they have mentioned about a meiotic, so we have to give a agent which will dilate the pupil well. We are not interested here in the cycloplegic action. So again, I want to know the exact question. What was that? ठीक है ना? So if you can help me with the question, that will be great. Now, friends, let's talk about the next one. The next one says it was a very simple question, something about fungal corneal ulcer, है ना? कितनी बार तो पूछा है उन्होंने. So there was a picture given which has feathery margins, isn't it? So feathery margin was given and there's a history of trauma with a sugar cane fragment. इससे easy तो क्या ही होएगा? We have learned so many times F, fungal corneal ulcer, feathery margin, and you have a fixed hypopion. So this was a very easy question. You have to find out fusarium, aspergillus. अगर दोनों ऑप्शन में थे, कुछ बच्चे तो कह रहे हैं मैम aspergillus ऑप्शन में नहीं था, there was fusarium. So considering that if fusarium is the option, aspergillus is not there, fusarium is there. If you have aspergillus, so you have to tell me what was there in the option. Were both the things there in the option? Okay, bache? You should know it's a fungal corneal ulcer, as simple as that. Now, guys, it is also very, very important. We have discussed a lot of time before our NEET PG exam. There can be a question on visual field effects related to AION, isn't it? We have spoken about altitudinal visual field effects. So this time they have given you a question where there is a problem in the inferior visual field. A patient comes to you with a decrease in vision. There is a swollen disc also. Now, guys, listening to the term swollen disc, some people thought of papilledema. But do you have a loss of vision? Do you have a decrease in vision in papilledema? Absolutely not. And do you expect an inferior visual field effect? No, no, no. In papilledema, there's no visual field effect except for a large blind spot. So this papilledema to gaya. Now, if you know about AION, you will understand that in anterior ischemic optic neuropathy, there's a problem with the blood supply of the optic nerve. So if optic nerve blood supply is gone, you can have a swollen disc, a pellet disc also. Okay, and classically you get an altitudinal field effect. Here we get an inferior visual field effect. So the correct answer is AION. So I would say this was a very, very easy question. Okay, now, some people also say, ma'am, there was one more question and this was not mentioned. Rather, the question was about which part of the visual pathway was affected. If that was the question, guys, okay, if that is the question, then remember, obviously, if there is an inferior visual field effect, superior optic nerve fibers should be gone, है ना? Superior optic fibers हो सकते हैं. So, you have to see what exactly was the question. Most of the students were telling me about the AION thing. So, I think this was the question. This was such an easy question here. Now, guys, again, there was a OCT picture. The patient had diabetes and hypertension and OCT picture was given. So, very clear-cut picture. There were cysts here. So the diagnosis has to be a cystoid macular edema, isn't it? This is a cystoid macular edema, right, everyone? Very easy, very simple. You should have a knowledge about different OCTs. So this is a picture of CSR. Had this been the question, there's a fluid collection in this area. This has to be CSR. And if the picture was black and white kind of picture, this is again a CSR. Okay, black and white wala OCT. Simple. Now, guys, this was a question related to pathology. We were expecting one question in retinoblastoma. It was a very straight question. Genetics of retinoblastoma, isn't it? You had a question on white reflex in the eye. There was leukocoria. And these rosettes are definitely Flexner Wintersteiner rosette. ये तो बहुत ही simple था. अभी क्या होता है retinoblastoma? This is retinoblastoma. It's a tumor suppressor gene, isn't it? So if this tumor suppressor gene has a loss of function, the tumor will happen. As simple as that. है ना? P53 की तो कोई बात ही नहीं है. So this was a straight question. There was a loss of a function of RB gene. Knutson's two-hit hypothesis. There's lots of heterozygosity. So students, genetics of retinoblastoma has always been important. INI set में अभी आके चुका है retinoblastoma में. Isn't it bilateral, unilateral? So we should know genetics. We should know everything about this RB gene. It was expected. So I think this is also an easy question. Now, the next question, this is an image-based question. We were expecting a question on amblyopia, the types of amblyopia. So many times we have discussed this. So let's talk about this question. It says a young boy comes with unilateral long onset of squint. Hai na? You can see there is a esotropia, which is supposed to be congenital and long standing squint. So if you have such amount of high esotropia, congenital squint, do you expect a good vision in the SI? No, you expect a poor vision. Hai na? So this is the vision in the affected eye. Hai na? There is no other structural abnormality. So can I expect an amblyopia? This eye has become lazy. And why this eye has become lazy? There is a cortical suppression. This is one of the most important things. It is one of the central nervous system mechanisms to have a good image formed by a good eye. And whatever image is formed by the deviated eye, it's a poorly formed image. So this is a mechanism, the central nervous system mechanism to inhibit that image. उसको खत्म ही कर देता है, वो कह रहे हैं उसको lazy कर दो. So this is the reason of his decreased vision. They have asked you very sweet kind of question, है ना? But if you look at the other options, none of the other option is fitting to it, है ना? बाकी तो क्यों ही होएगा? Why would there be optic nerve compression? Why would there be a retinal degeneration? It's as simple as that. You have a amblyopia. There is a suppression of the image, but poorly formed image by the central nervous system. So this is a question on amblyopia. So guys, I would say in ophthalmology, the questions were really, really good. There was one doubt, one twist about the adenovirus and enterovirus wala question. And the second, if I get to know what was the exact language of the question about meiotic, midriatic wala question, if meiotic word is not given, then definitely atropine we give. But if meiotic is given, then it becomes, gray zone hai. कि आप phenylephrine देंगे या atropine देंगे. Okay, so these are two questions which are little dicey, little doubtful, but if we get to know the options, we'll frame it better for you. So guys, enjoy your time. NEET PG 2026 is over for you. And relax, keep calm, and trust your preparation. You have done a lot and lot of hard work, so results will be favorable, I'm sure. Enjoy, relax, and be with your family and your loved ones. Take care. Bye bye.
Hello, everyone. Good evening. Dr. Pallavi, your dermatology faculty here. Very happy to come with dermatology questions where I know that most of these have been discussed in the class. Overall, the paper was moderately tough. It was not an easy paper, though the questions looked easy, but the options were pretty close. So that is why I would call it a moderately tough paper. A few images were asked from dermatology also, but overall, images were not as dominant a feature in the exam, which has been the case over the last few years with the exams. They have been moving away from images and getting into more descriptive questions. So that is what we saw here also. And another surprising thing in dermatology that I saw is that normally we have a lot of questions from the vesicular-bullous disorders, from the sexually transmitted infections, but this time there was no question from the vesicular-bullous disorders. There were no questions from the STDs except one question on Neisseria and the Waterhouse-Friderichsen syndrome, but that's an indirect question. So what we always expect in derma, that is something we didn't see. Yes, there were integrated questions. That is something that's expected. But overall, this was a very different kind of a paper when it comes to dermatology. Though the questions were easy, but the questions were not what you would always expect in a paper. That is the only different thing that I see here. That's the only different thing that I see here. Now, coming to the discussion, let me just open the comments on the YouTube. Till that time, tell me how do you people find the derma paper? Anything that you would want to tell me? A lot of these questions will also be based upon the recall. A lot of these questions would be based upon the recall. So there will be some discrepancy in what you might have seen in the exam and what you see in the questions here. So if there is any conflict, there is any different option, then you please let us know. We'll be correcting it when we prepare the final recall. So coming to the question here, a patient presents with cutaneous lesions as shown. So a patient presents with cutaneous lesions as shown. What we see in the image is multiple hypopigmented macules on the back. So what we see is hypopigmented macules on the back. A KOH preparation is performed to identify the causative fungal infection. What is the characteristic KOH finding expected in this case? So this is a question that is asking us about hypopigmented macules on the back. There could be a few reasons for that, but we don't have to delve much into what the differential diagnosis could be, because the question here is specifically asking us what the KOH findings would be. So KOH finding, when asked, points towards a fungal infection. It's also wording that in the paper. I don't know if this was exactly there, because if this is exactly there, then though, it's not very difficult. You can easily answer this question. This is a case of pityriasis versicolor, and what we see here is a banana and grape appearance. Pretty simple. Ball and claw is the histopath of lichen nitidus. That would be multiple hypopigmented papules on the flexion and the extensor, on the extensor surfaces and the joint surfaces, especially in children. Cigar-shaped yeast cells would be sporotrichosis, not something that we see here. Broad asepted hyphae with right angle branching, not what we see here. So the correct answer here is the spaghetti meatball appearance or the banana and grape appearance. This question, a patient with leprosy develops an acute inflammatory episode, worsening skin lesions, neuritis. Which of the following statements is true regarding the lepra reaction? So this is again another very, very direct question here. It is a question on leprosy, especially leprosy reactions, which is very much asked in the paper. They asked it this time also. I mean, this is one question which is repeated in the INI set, in the FFG and in the NEET PG. So when there is a worsening of skin lesions, what is the type of reaction that we see? Worsening skin lesions is a type 1 leprosy reaction. And if you see new lesions, then that is type 2 leprosy reaction. So here we have type 1 leprosy reaction. Do you see lepra bacilli in foamy cells? No, because lepra bacilli in foamy cells would be seen in LL leprosy, and the type of reaction that we see in LL leprosy is type 2. Zn staining, this is not zinc, this is Zn staining done with 20% sulfuric acid decolorizer. No, what we do in leprosy is a modified Zn staining where there is a 5% acid used. So this is also not correct. What about the next option? Nerve thickening hypoesthesia seen. So nerve thickening, yes, can be seen because type 1 leprosy reaction is generally seen in the borderline leprosy. This is generally seen in the borderline leprosy. So in the borderline leprosy, nerve thickening can be seen, hypoesthesia can be seen. There is nothing much mentioned on the lepromin test here. Can you tell me what was the option here for the lepromin test? It is positive, it is negative. Is it positive? Is it negative? I think lepromin test negative should be the option here, because if it is positive, then this also becomes correct. So if you look at all the options, A is wrong, B is wrong, and D, if it is written as lepromin test negative, is wrong. So the correct answer here is option C, because what we get from the worsening skin reactions and the neuritis is type 1 leprosy reaction seen in borderline leprosy, where this is the only thing that is correct. Now, coming to this question, lepromin test type 3 hypersensitivity. Oh, okay, so I've got a correct option here. It said like lepromin test is a type 3 hypersensitivity. So that's absolutely wrong. What kind of hypersensitivity do we see in lepromin test? That is certainly not type 3. It's a type 4 hypersensitivity that we see here. So option D is wrong. Again, it makes option C the correct answer to this question. Now coming here, a young adult man presents with recurrent, painful oral and genital ulcers. As you can see in the image here, there are multiple ulcers. You can call them as aphthous ulcers, because when you have these kind of well-defined ulcers with a yellow necrotic slough on the surface surrounding erythema, these are classic aphthous ulcers that we see on the oral and the genital mucosa. And that is something we see in the image here. So I've been told that both the oral and the genital ulcers were there in the image in the same question. The lesions heal spontaneously, but they tend to recur. So in short, we have recurrent, painful oral and genital ulcers. No recent trauma, no sexually transmitted or maybe no sexual activity is what the question might be wanting to tell us. Based on the clinical presentation, what is the most likely diagnosis? A question like this was always expected, because last year in the INI May 25, they gave a question similarly, recurrent oral and genital painful eruptions. There is a histopath of vesicles is shown below. What is the drug of choice? So when it says histopath of vesicles and the histopath showed acantholysis, ballooning, degeneration, the answer was herpes. But when that question came in the INI set May 25 last year, I have been telling since then that the most important DD to this is the Behçet's disease, and a question on Behçet's is expected. We did that in the NEET PG MIQ this year, just a month back, where this similar question I gave. And the correct answer to this is Behçet's disease, which is a type of vasculitis with neutrophilic infiltration. It's a pan-vasculitis. Secondary syphilis would show condyloma later. They would be solid gray papules and plaques with a moist, oozy surface. Not this, plus condyloma later would not be recurrent lesion. And there would be a history of primary syphilis that is a painless ulcer. So anyway, that's out. Pemphigus vulgaris can come with oral ulcers only. That is a variant of pemphigus which is called as oral pemphigus vulgaris. So you only have oral lesions there. But that would not be recurrent. In that case, these would be non-healing lesions, and they are more of erosions. You don't see these kind of well-defined ulcers with a yellow slough. Pemphigus erosions are persistent. They are non-healing. They don't have a yellow surface. They have a red surface, and there is no history of recurrence there. They are more of persistent. Any idea on what was the fourth option here? Any idea on option D? Any idea on option D? So whosoever gets this question back to their mind and can tell me what is the option D, please write it. It will help us make a proper recall. So the correct answer is D. Well, they should have put herpes in the option here. This question is not complete if they don't put herpes in the option, because they would want you to rule that out. I would be the examiner. I would be doing that. Anyway, so a young woman presents with recurrent episodes of swelling involving the eyelid, the lips, as shown below. So in the image here, we see that there is a swelling on the lips, and the overlying skin is normal. The overlying skin is normal. I've been told that option D here was IgA vasculitis. IgA vasculitis means Henoch-Schönlein purpura. What you would see here would be palpable purpura, not ulcers then. So this is also out, this is out, this is out. Again, the correct answer is Bessett's. So here, coming back to this question, recurrent episodes of swelling involving the eyelid, the lips, she has no associated urticaria. Which of the following lab findings is most likely to be present? So in the image, we see the swelling, we see the overlying skin is normal. What is the diagnosis? The diagnosis here is angioedema. The diagnosis here is angioedema. Now, this is a question which is an integrated question. It has the complement pathway knowledge that you get from path, and it has the clinical part, which is derma. So this is a classic integrated question between path and derma. So tell me, what is most likely to be present? Do you have elevated C4 levels when angioedema is happening? No, in fact, complement 4 levels are a screening test for angioedema. And what we get here is low C4 levels. That's a screening test. So this is out. Decreased C1 esterase inhibitor, if this is hereditary angioedema, where a patient may get recurrent lesions, then in hereditary angioedema, yes, levels of C1 esterase inhibitor are decreased. Decreased C3, what would happen? No, C3 levels are normal in hereditary angioedema, so you would not see this here. IgE levels absolutely have no relation to angioedema without urticaria. Yes, if it is angioedema with urticaria, the levels may be a little raised, but it is simple angioedema. Question says there is no urticaria. There is no relevance of IgE here. So the correct answer here is option B, decreased C1 esterase inhibitor. Another question that was always expected, because this allows them to integrate both path and derma. Now, coming to this question, a patient presents with white patches covering more than 90% of the body. What is the treatment for making whole body same color? Whoever has made this question must have had a patient visit for this, because this is the very common thing that we get in the clinics in patients who have vitiligo involving more than 90% of the body surface area, which is called as vitiligo universalis. In vitiligo universalis, look at the face of this patient. She does not like these brown patches here. She would rather have her whole face of the same color. And for making whole face of the same color, you have to depigment the normal skin. You have to depigment the normal skin. You don't have to bring back color to the vitiligo lesion. So you would not be marking narrowband UVB. If there was a fourth option of steroids here, you would not be marking steroids here. Girl's father also has same. Okay, oral steroid was, yeah, see, again, being an examiner, I think like this, steroid would be in the option if they are talking about vitiligo and they want to confuse you. So for someone who would not understand what it is, they would end up marking the treatment of vitiligo, which is not to be marked. So UVB will bring back color. We don't want color here. We want to remove the color. Steroids would again bring back patchy color. We don't want it. It is not to be given here. You have to remove the color. So to remove the color, you have to, hydroquinone would cause a temporary, see here the confusion is that hydroquinone would inhibit tyrosinase enzyme, but inhibiting tyrosinase enzyme is a temporary thing. You bring down the color, but you cannot completely remove it, and once you stop hydroquinone, it comes back. So some of you who might have thought of hydroquinone, no, that's just a temporary reduction. It's not a permanent reduction. For permanent reduction, what we have to do is we have to kill the melanocytes. Killing the melanocytes is done by this technique, which is called as toxic leukoderma. So you have to give a chemical which is going to kill the melanocytes and make the skin color white. The correct answer to this is monobenzone ether of hydroquinone. So the correct option here was monobenzone ether of hydroquinone, which is MBEH. I have talked about it in the topic of chemical leukoderma, and this is something that can be used in these patients to reduce the color, making this the correct answer here. Making this the correct answer here. Coming to this question, a child develops multiple small scaly lesions over the trunk following an episode of sore throat for which antibiotics were prescribed. What is the most likely diagnosis? I want to ask you all, if you saw an image here, there are some recalls where I am getting an image of pustular lesions in this question, but that does not fit here in the options. Either the options were different or was there an image? I would want you all to tell me how this question was framed. Because according to this, if you have a child who has sore throat, antibiotics don't really matter here, but sore throat, antibiotics means it was a bacterial cause of the sore throat. And bacterial cause of the sore throat means streptococcal pharyngitis. Streptococcal pharyngitis in a child can lead to these small red scaly lesions, which is called as guttate psoriasis. And guttate psoriasis is also called as eruptive psoriasis. Not in a child, it was a female. Okay, so this is a female. And there was no image in this question. There was no image here. So pustular lesion seen in the background. 10 was also in the option. So was there an image here? Okay, there was an image. In the image, we saw pustules on a background of redness. Okay, so pustules on a background of redness, again, that would not make eruptive psoriasis the correct answer here. That would make pustular psoriasis the correct answer here. See how a change in wording, how an image there or not can completely change the recall. So I'm so glad that you were able to tell me what it was. Okay, so as per the recall corrections that I'm receiving, recall questions that I'm receiving, what it says here is that this was a female who has small scaly lesions, plus there was an image of pustules on a background of redness. That would not make it eruptive psoriasis, that would not make it tinea versicolor, not pityriasis rosea. In that case, the correct answer would be pustular psoriasis, and there was another option here, which is subcorneal pustular dermatosis. Subcorneal pustular dermatosis is another type of IgA pemphigus. That's a different thing that will not be seen here. So the correct answer in this scenario would also be pustular psoriasis. This will also be pustular psoriasis. Coming to this question here, a farmer presents with nail overgrowth, dystrophy. Causative organism is T. rubrum, which is the most common cause of onychomycosis. Based upon its natural habitat, to which group of dermatophytes does T. rubrum belong to? Two questions came related to this, confusing. Okay, so if you could tell me what are the two questions in the chat. One was on psoriasis, one was on this. Please let me know. That would help in making a proper recall. I have been told that there was one question where the answer could have been pityriasis rosea, and another question where it could have been pustular psoriasis. So yes, I have also been told that there could be two questions, but if you could word it down, write it down, that would be very nice. Coming back to this question, T. rubrum, what is the category where it belongs to? What is the category where it belongs to? It's not geophilic, it's not zoophilic. T. rubrum is an anthropophilic fungus. That is why it does not cause a lot of inflammation. It causes relatively low inflammatory lesions of tinea. So the correct answer here is anthropophilic. Coming to this question, a patient presents with fever, rash as shown. Which of the following shall be prescribed? What we see in the image is a little redness in the center and an annular rash surrounding it. Okay. So when you have fever with this kind of a single annular rash, what is it that you have to think of? Without much details, it's very difficult to pinpoint, but when you look at the options, there are antibiotics here that might be a bacterial cause to it. And the bacterial cause to this is erythema chronicum migrans. What causes erythema chronicum migrans? This is a rapidly enlarging annular rash, can have fever along with it, caused by Borrelia burgdorferi. What would be the antibiotic of choice? This is doxycycline. These infections, which are the extra bacterial infections like anthrax, croup typhus, erythema chronicum migrans, these are all very favorites of the exam. They like asking these. And here, this is erythema chronicum migrans, Borrelia burgdorferi, antibiotic of choice, doxycycline, making this the correct answer here. Now, this is another question where there was a little doubt. Please let me know if this was the kind of question that was there. A patient presents with a generalized eruption, which is characterized by scaly lesions with the colorative scaling. What is the most likely diagnosis? Is this the question that was there? Okay, here this was this the question? Okay, they say this was not the question. So we'll have to figure out what the question was. For now, these are the dermatology recalls. I hope you got them all correct. I would be very happy to know that you got these questions correct. Wishing you all the best for your result. Please note down any other options, any other questions that you see. We will be noting them in making the final recall. Thank you. All the best for your result.
Hello, dears. Good evening. I know it's not the right time to go for a paper discussion, but I know you all must be feeling very tired. I won't take much time. This is just a first insight of the paper. So we won't be getting all the information that is required for discussion. Obviously, this is based on the recall from students. So naturally, many things will be missing as of now, but definitely we'll come up with a detailed question discussion afterwards. So I'll take hardly 5 to 10 minutes to get you the feel of how the question was and what all were the answers. Okay. If there are any changes, please let me know. Okay, so there were around 20 questions. I got around, I heard there were more than 20 questions, but what I have with me currently is just 17, 18 questions. Anyway, we'll see it. So this, and okay, before that, let me tell you, all questions were expected. I couldn't see even a single question that was not there, which we have expected. And everything was, all the questions were from the notes, and so happy to get messages from students that the community medicine part was easy. Okay, so let's see. Not much of your time. Okay, guys. So there was, see, a scatter plot was given, and the question was like this. A correlation study was conducted. The investigator analyzed the food intake patterns across various countries. It was observed that the developed countries had more protein consumption than other countries. Some said they have mentioned about protein as well as fat. I'm not very sure. Anyway, the results are plotted on a scatter diagram. The question is, what is the study designs? Guys, we have discussed many times that scatter diagram is also known as correlation diagram, and correlation diagram is something that you draw in a ecological study design. So there are many clues, because when you simply even without the scatter diagram, we know that you are comparing two different populations, and a country, the protein intake and various countries, their average consumption. So we know that this is definitely a ecological study design, and scatter diagram is something which will give you the correlation between two different populations. So anyway, this is ecological study design. So there is no doubt about it. And the next question, a program manager was planning to execute a project, but he's uncertain about the time taken for each activity. Which of the following should be used? So what did you write here? Here, everybody said, Madam, it was an ecological study design. So directly they told me. Here, I think they have some doubts. Students might be having some doubts. What did you write here? Actually, I'm unable to see your chats. Okay. I think I'm unable to see. Anyway, I'll just discuss. Okay. So guys, we have, this is nothing but, this is a network analysis where, you're trying to find out the time taken. Okay. So in network analysis, we have two different methods to do it. One is critical path method and the other is PERT. That means program evaluation and review techniques. Both these are coming under network analysis. Okay. And the major difference between PERT and CPM is that in PERT is something that you do earlier or as a first step when you are not sure about how much is the time taken for each step. And in network analysis, I've told you, you are arranging the steps in a project or a program one after the other along with the time taken for it. But the difference is that in PERT, you are not very sure about the time. Okay, you are finding out the time by doing it. Whereas critical path method is something that you are doing as a second step once you know the time. So I'm not going into the details right now, but please do understand that since it was said the time taken for each activity was uncertain, students clearly said uncertain was written, then the answer has to be PERT. If the time taken you knew, then the answer would have been critical path method. And critical path method, there you are targeting critical path itself means that the time, the the activity which takes the longest time duration, right? And Gantt chart is something different. Gantt chart is also known as timeline chart, where you are actually arranging according to the time taken. Okay, that is timeline chart. So time, we don't know. Definitely, it is not Gantt chart. And management by objectives, or MBO, is a different method where you have some objectives and you're trying to achieve those objectives. So here the answer is PERT, or D is the answer. Moving on to third question. If India is in the fourth stage of population growth, what reforms need to be implemented for this stage? Okay, we know about fourth stage in demographic cycle. In fourth stage, birth rate is less and death rate is also less, right? And it is known as the low stationary phase. It is low stationary phase. And in low stationary phase, since death rate is less, that means life expectancy is more. Life expectancy is more. If life expectancy is more, naturally, what happens? Non-communicable diseases, geriatric problems, all these will rise in that population. And the option is NCD and geriatric. So that is what the government needs to, the reform that you need to bring out will be to tackle more of NCDs and geriatric problems. Okay. Then question number 4 was to calculate attributable risk. And attributable risk is something that you get from a cohort study. And they have clearly mentioned that there were 7,000 smokers, 3,000 non-smokers. I'm not very sure whether same numbers were given. This is what most of the students said. 70 out of 70 smokers developed lung cancer and 30 out of 3,000 smokers developed lung cancer. And the question is, what is attributable risk? What is attributable risk? So guys, attributable risk, you have to find from this. Before that, I'll just tell you how to draw a 2-2 table. Even without 2-2 table, you can directly find out the answer. Anyway, this is how the 2-2 table will look like. You have 7,000 smokers, 3,000 non-smokers, 70 developed lung cancer, and 30 developed lung cancer out of non-smokers. So attributable risk is, incidence among the incidence among the exposed minus incidence among the non-exposed, right? So incidence among the exposed will be 70 divided by 7,000, right? Incidence among the non-exposed will be 0.89 was in the option. Okay. Okay, dear. Was this the exact question given? Because from the question given, I don't think 0.89 will be the answer. Anyway, let's see. Okay, so incidence among the exposed, 70 divided by 7,000. Incidence among the non-exposed or the smokers, non-smokers would be 30 divided by 3,000. So both will give you the answer as, 1%, right? Or 1. So attributable risk will be 1 minus 1. That means incidence of the exposed minus incidence of the non-exposed. So you will get it as 0. Okay, so here the answer will be 0. And if you are going for attributable risk percentage, then that divided by incidence among the exposed. That means again 1. Into 100, you will get it as 0. Okay, so here I think the answer, if this is the question given, then the answer will be 0. And I heard that there was a question regarding case fatality rate as well from JE. I couldn't get the correct numbers. This anyway, attributable risk and case fatality rate, both we have discussed in detail in class as well as in Instagram. I have actually discussed that few days back, how to do if you are given some numbers with the help of some numbers. But here, which were the numbers given, I'm not sure. You know what is case fatality rate? Out of those who got JE, how many died of JE? Okay, so that will be the formula. And if you know these numbers, if you can help me with the numbers, I can do it now, but I haven't got the numbers. It was 3 and 30. Okay. So you can put 3 here. Okay, thank you, dear. Into 100. So it will be 10%. So here the answer will be 10%. Okay, thank you very much. Thank you. So it is about JE. So they have said that there were 30 JE cases. Out of them, 3 died. So naturally, the case fatality rate answer will be 10% here. Okay, thank you. Thank you. So these were, and I'm so happy these 2 questions came because we were very much expecting these 2 questions. And that's why, a few days back also, I have given that problem-based question. And next, another very much expected question with regard to hypertension. Identify 4 and 6. This is, okay. So, guys, this is rule of half. Okay. And the question was, what is 4 and 6? Rule of half, I'm not going to discuss it. It is for hypertension in the community. And it is divided into 3 halves, right? So out of total hypertensives, half of them, okay? See, this is the hypertensives. Out of them, half are diagnosed with hypertension. Okay. And out of those who are diagnosed with hypertension, half are taking treatment. And out of those who were taking treatment, only half are adequately treated. That means they have controlled hypertension. And the question is, what is this 4 and 6? See, this 4 is those hypertensives who are undiagnosed, because only this much is diagnosed. So naturally, this 4 will be undiagnosed hypertensives, right? And the 6 are diagnosed hypertensive, but they are not taking treatment. Okay, so the answer will be B. Undiagnosed hypertension, diagnosed and untreated. So undiagnosed is 4 and diagnosed but not treated is 6. Okay, so that was the answer. Oh, okay. So, okay. So, guys, just going back. Anyway, you know how to do it, right? So there is a change in the numbers given. Now it is said that there were 400 cases of JE, out of them 4 death. Okay. Anyway, you know how to do it. If this was the answer, I mean, these were the numbers, you know how to do. 4 divided by 400 into 100. Okay, so that way you can do it. Anyway, you know how to do it. That is the point. Then 7th question was, a patient with minor bruises who came to hospital. Which of the following is the most appropriate triage code for this patient? Guys, the patient is injured, but he's coming walking. And I've told you many times, walking means ambulatory patient. Ambulatory patient means green. Okay, you know what is yellow, black, and red. Okay, and red means patient's vitals are unstable. Yellow, injured, vitals are stable, but the patient is unable to walk. If the patient is walking, then that becomes green. So here the answer is green, which is C. Okay. Another very much expected question, which of the following is a beginning and ending of contraction phase of family cycle? This is family cycle. We have discussed it multiple times. There are 6 phases. And the contraction phase, it is beginning with first child leaving home and it is ending with last child leaving home. Now let's see whether that answer was there or not. Yes. Look at your option number. Actually, this pen is not working. Look at the option number B. It is first child leaving home and last child leaving home. So it is B answer. Another question. Actually, I'm not very sure whether this was a question given. A lecturer, after conducting a lecture, divided the large group of people into smaller groups to make them actively participate. Which is a most likely teaching model being followed here? Okay, from the options that I've got, this is an active method. Okay, passive means kind of lecture. That is one way. Just teacher is or the lecturer is giving lecture and others are simply sitting and listening. Demonstration means, they are showing something. So none of those could be the option. One-to-one is again, it's a interpersonal communication. So considering or ruling out all the options, the answer will be active. But I have a strong feeling, I just want to know whether bus discussion was given or whether workshop, any of this was mentioned. If any of this was mentioned, then the answer would be any of this. Wrong options, which one, Ashik? This is what I have received. Which one, Ashik? Here? These were not the options. Then what were the options? Ashik. Okay, Rashid. These were not the options. Just let me know what are the options if you have time. Anyway, question was this. Am I right? Question was the same, right? That's why I said there will be, this is mainly based on the recall from students. Majority of students are unavailable right now because, after an exhausted exam, they are chilling. Quite, understandable. FDG was there. Okay. If FDG was there, one-to-one active demonstration. Okay, if FDG was there, I will go for that. Which one? But even then, people were introverted, so they didn't talk much. Hence, they were divided to facilitate interaction. Oh, that is how it was given. People were introvert, so they didn't talk much. Okay, so 9th circle was asked. Acha. Then it's a pakka repeat question. If it was 9th circle, every time they asked, because when I took class, I said this is what they always say, which is the smallest circle. Definitely, smaller circle is those hypertensives who are diagnosed and treated. Okay. Then, it's pakka PYQ. Okay, thank you. Introvert people as doctors, what will be your method? Okay. Was FGD given? Was FGD in one of the options? These were the options that I have received. In FGD also is done like this. Okay, you're dividing them into different groups, but it mainly depends upon. Oh, I should thank you guys because right now, this is the point I'm getting correct questions and options. Okay, if FGD was there, FGD is also done like this. If any of this was there in the option, then you can go for it. Okay. Anyway, within 2 days, I'll come with a complete recall. Okay. FGD was not there. Okay. FGD was not there. Someone said FGD was there. Anyway, if none of these were there and these were the options, which were present, then the only option that is fitting is active discussion. So just to make them active, like I think Ashik said, they were not interacting much. So just to make them active, they would have divided them into different groups to make the, the group, dynamics active. Anyway, we'll move on to the next. I heard this was a match the following question. I mean, these were, the question is from biomedical waste management and another expected question. And around 6 options were given, and which all will go to, or these items will go to which all colored bin was a question. Anyway, let's see the correct answer. Placenta, it's an anatomical waste, that will go to yellow, right? Gauze piece, again, yellow. Catheter with blood. I said, RPT, rubber item, plastic item, tubes will go to red. Cytotoxic drug, again, yellow. Syringe. Syringes, I heard syringe with needle as well. If it is syringe alone, then red. If syringe with needle, then that becomes, white. And metallic implants, blue. So these were the 6 options I got from majority of students. Okay, syringe with needle was there. Okay. Exact same question. Thank God. At least one question is exact same question. Okay. So we got the answer. Exact same answer we got. A man residing in Uttarakhand. I heard a man residing and someone said a resident, a doctor, something like that. I don't know. Anyway, a man residing in Uttarakhand, he's presenting with fever. On examination, a black colored lesion. Someone said it was simply mentioned as a black colored lesion. Someone said eschar was mentioned. Anyway, the answer is quite clear. Present near the umbilicus, which is the following is the most likely diagnosis and the causative organism. Okay, so we know it is scrub typhus. Scrub typhus with Orientia suzugamushi. Okay. Then a patient comes in for mumps vaccination, which is the following is the strain used in vaccine. Another direct question, which is strain used in mumps. We know it is Gerald Lane, right? Edmund Sagram is for measles. Mumps is Gerald Lane, we have seen. Rubella, that also we have discussed many times. RA 27/3. And Nakayama is a strain that we use in Japanese encephalitis vaccine, which is killed. And SA 14/14/2 is what we use in live. And Oka strain is, where is it gone? Oka strain is for chickenpox. That is for varicella. This is for varicella or chickenpox. So here the answer is D. Nothing more to discuss there. Again, not sure about the question. Researchers have found a correlation between age and PFR. It is noted that the PFR increases with age, but this increase is not observed in all, which is the most likely type of correlation. As one increases, the other increases, which is positive correlation. But it is said that it is not found in everyone. So it is not very strong. So the only option which fits here is weak positive. Definitely it is positive because as exposure increases, the outcome increases. Here the exposure is age and the outcome we are looking is PFR. Okay, so as one increases, the other increases. So naturally it is positive. And here it is weak positive. Was this question given? Oh, transmitted by mite was also given. Okay. Anyway, the answer is scrub. And what about this? A 60-year-old man presents with complaints of bone pain. X-ray shows decreased bone density. And physical examination reveals findings shown. This picture was also given. This is nothing but mottling, dental mottling, right? Dental fluorosis. Mottling, that is dental fluorosis, right? And in fluorosis, we know that bone density will also be affected. So the answer is fluorosis. Okay. We have discussed this multiple times. Definition of XTR and pre-XTR, both we have discussed. So what is the definition of XTR? Direct question. It is MDR or RRTB plus second line injectables are not there anymore because we have seen that we are not using injectables anymore as first or second or third option. If everything fails, then only we will think about giving injectables. Okay. So MDR plus RRTB with fluoroquinolone, that is pre-XTR, right? Plus one of the second line, one of the group A, which is either linezolid or bedaquiline. Resistance to MDR, RRTB plus I think fluoroquinolone also should have been given. But from what I have received, fluoroquinolone was not given. I think fluoroquinolone, was it the same question? Okay. Fluoroquinolone plus bedaquiline linezolid. Okay, so this is the definition. MDR or RRTB plus any one fluoroquinolone with resistance to one additional group A. So this is the answer. Okay. Rest of the questions, I'll show you the question. I haven't got the complete question. This was one of it. I got the answer, but other options I'm not sure. A pregnant lady with more than 24 weeks gestation can undergo MTP under which of the following conditions? This question was there, no? Okay, DEXA scan value. Oh, they have given DEXA scan value. Okay. Thank you, Rahman. This question was there, no? Rest of the options, I'm not sure. Anyway, after 24 weeks, if someone wants to undergo, normally it is only up till 20 to 24, we know, for special category. And after 24, you have to get approval by the medical board, and it is usually for conjugate normally. I heard this option was there. And this will be the answer. Rest of the options, I don't know. Give me some time, I'll collect. No idea what the question was. Some question related to IM and CI. Some said it was ARI control program. Some said it was pneumonia. Was such question given? Was it given? I don't know what the question was. Anyway, IM and CI I've taken ARI control program, the revised guideline. We know how pneumonia is classified, and a medical board can terminate pregnancy till when? Substantial fetal anomaly. Okay, weak. Okay, so what were the options given? Anyway, I think that must have been taken by Gayathri ma'am as well. So I'm not going to waste my time on it. You might have already seen that. Madam also might have taken it. Her discussion is over, right? So we'll go to the next. Pneumonia. I haven't got the questions. Anyway, this was there. And one question from malnutrition also I heard. This is the last one I have received. Was there any question? Was it from growth chart? Anyway, we are running out of time. So I hope you got an idea about which are the PSM questions. I'm sure more questions were there. We will see a detailed explanation of all the questions in another 2 days. Okay. So thank you very much for your patient listening. And I'll give you my WhatsApp number. For those who do not have my WhatsApp number, you can ask me your doubts, 9895449210. I'll be available. Okay. Bye.
exam, and I know the paper was like as per the micro is concerned, it was not so difficult, and I suppose we have covered up everything in our notes also and in our lectures also, whether it is in the online live or in the app. And definitely, you must have done wonderfully well. Just a quick recall regarding all of these particular ones, and obviously, these are not the real recalls like which we have written up here. So, whatever you tell up in the comment section, that according to that will make up the final ones. So, as such, just the topics and some of the important choices which we could able to get up, we'll talk about them. Okay. So, guys, the first question, without wasting time, let's because you will also be eager to go up for the party or sleeping up today. So, Deep Shikha, you have written potassium telluride was also in the option. Okay. So, guys, you know, obviously, this is a suspected case of diphtheria with a pseudomembrane, and we have taken the pseudomembrane and we put it on which particular culture media? The answer is Loeffler serum slope. That is for the 6 to 8 hours colonies will come in this, and which is the best culture media for conivectin diphtheria. As Deep Shikha have told, the best culture media is potassium telluride agar. So, this particular question used to come way before also, that which is termed as the best and which is for the early diagnosis, and for the early or rapid growth, obviously you will need what, you will need this Loeffler serum slope, and the best culture media as such is what, potassium telluride agar, on which black colored colonies they come in how much time, in 2 days around. Okay, in 2 days around, so that you already know. Definitely is asked early also. Other than this, guys, this was there. A farmer from Uttarakhand presents with fatigue and fever, and black Keshka was being talked about. So, obviously, if you have done the lectures, I have already talked about the scrub typhus, and the causative organism is Orinchia susugamusi, and the transmitter is mite. Okay, transmitter is mite, and basically the larva of the mite, that is termed as chigger, and that's why this particular disease is also termed as what, chiggerosis. And this you already know that this is OXK, strongly positive. Okay, protease antigens for this particular scrub typhus. OXK, strongly positive for scrub typhus. Is it fine? So if I zoom it up for you, so obviously the scrub typhus done by Orinchia susugamusi and OXK, this particular heterophile antigen test, which is termed as wheel phallic test, is positive for scrub typhus. And these are the antigens of which one particular one, guys? These are the antigens of the protease, as you know. Okay, they are the antigens of the protease. So I think Deepshikha, you must have done this also correct in your exam. Okay. So Lyme's disease clinical case image treatment of the choice. So if you have seen up, I told up doxy and ceftriaxone both are used actually for this, but doxy is a better option in which you will go for the early stage and all that. And I suppose they have given up the erythema chronicum migrans, the target, that is the target lesions or bullseye lesions, which we call up in the Lyme's disease. So guys, this medical instrument was there. Shaki tape is not. Acha, you are telling for PSM. Okay, the medical instrument is shown in the image. So obviously they have talked about the. I don't know exactly this was there or something else was there, but I told up all the costly instruments like bronchoscopes, endoscopes. They all are sterilized by what, 2% glutaldehyde, which comes in the market by the name of SIDEX or SIDEX. Fine, so that you already know. Fine, this also already you know. And other than that, all these costly ones except your stethoscope, and stethoscope is sterilized by what? That is isopropyl alcohol. That is a spirit. That also, I suppose you have a wonderful idea for that. So this was there along with the picture. If it is there, and this is typically again a PYQ only, that is a tinea versicolor done by Malassezia globosa or furfur. And when you go for the scales, these particular ones, and put them into 10% KOH, that you find spaghetti and meatball or banana and grape. And one more I can tell you, short hyphae with round E cells. Next time it can come in the same way. Okay. Short hyphae with round E cells. So this is a favorite of the examiner. Again, it can come. So this is tinea versicolor. Hypo to hyperpigmented, scaling near the trunk also, over the back also, and over the chest also. Okay. So if you want to add up something in this, you can tell me in the comment section and all. Is it fine? Now, I'm not sure what was the question in this particular one regarding leprosy. Develops acute inflammatory episode with worsening skin lesion, neuritis. So obviously it is towards the lepra reaction. That is type 1 lepra, I suppose so. And what you can get up in these options, are these options correct, which are being written off? That you find lepra baseline foamy macrophages, or there are 2 3 questions of leprosy and there is a intermingle of the options and all. So you can tell that thing also. So lepra bacilli in the foamy macrophages, Z is staining with 20%, it is not there 5%. Okay, nerve thickening in hypoanesthetic conditions. Or lepromitous, I think it was given up, it is a type 3 hypersensitivity, if I am not wrong in this. So obviously out of these 4 obsolete or absurd options, this goes more good with the question. The lepra baseline foamy macrophages you will able to find out in this particular one. That is the type 1 lepra reaction. And you know type 1, type 2 lepra reactions. What is the drug of choice? The drug of choice is steroids for both of them. And in type 2, you can use a thalidomide also. Okay. In type 2, you can use a what? Thalidomide also. Okay. Now, this was there. A farmer presents with nail overgrowth and dystrophy. The causative organism is identified trichophyton rubrum. And based on the natural habitat, to which group of dermatophytes this rubrum belongs to. So basically our PSM questions also, and we also cover up this. So anthropophilic means exclusive of humans. That is rubrum and floccusum. And you know those particular diseases like tinea cruris, okay, that particular tinea pedis, they are being done by this particular epidermophyton floccusum and trichophyton rubrum, which is having a red color pigment also. Geophilic with the soil that attaches up. And remember like this, G for G, gypsum. Okay, so this question can come again, guys. And regarding the zoophilic one, that is the zoophilic canis, that is dog or verrucosum. If you remember up that particular disease, that is termed as Kirion, and that was a zoophilic one. Okay, and in that those names was there: Trichophyton verrucosum, Microsporum, the Trichophyton mentigrophytes, Microsporum canis. So basically a zoophilic infection and all. So from all that you can able to do this question, and I suppose this was the answer regarding the trichophyton rubrum if rubrum was asked in the exam. Okay, if rubrum was asked in the exam, so this is what is sounding the answer. Okay, anthropophilic, that is exclusive of humans. And if the infection you get from the like soil and all, so that is zoophilic. From the animals it is zoophilic. I suppose this is very clear to you. Now this question came, and again it's a PYT, previous year topic, and lot of questions they come about cholera toxin, but now they have gone up one more step forward, that which particular channels are being activated and all. So that was there in the exam. And regarding this, I have this for you, and this will clear up all your doubts. That cholera toxin is a AB5, means it's made up of A part and 5 parts of B. And B helps in binding to what? GM1 ganglioside receptors, that you already know. Okay, general manager of the company is the #1 position, I told you. Then what happens? Internalization. And this is being internalized by which particular process, guys? This receptor mediated endocytosis. For you, I zoom it up. Receptor mediated endocytosis. Then comes the translocation of A subunit. This happens up, and it is being translocated to the cytosol through the retrograde transport from the Golgi apparatus to the endoplasmic reticulum, as you can see in the picture also. Okay. Then happens the ADP ribosylation of G stimulatory protein. And somebody told up that this question also came, G stimulatory, G inhibitory. The G stimulatory is for this Vibrio cholerae, and for the pertussis toxin, it was G inhibitory. So basically, ADP ribosylation happens up of the stimulatory one, and this finally increase what, guys? Adenylate cyclase, and there is an increase in the cyclic AMP because of that particular one. Okay, and I suppose what they want to ask up is regarding these channels CFTR. Okay, and they open up, and there is a increase in the chloride secretion because of that, and the chloride and HCO3, that is bicarbonate, secreted into the lumen, and there is a decreased sodium absorption, and net result is what? Massive loss of electrolytes happens, and rice water stool, which leads to dehydration, metabolic acidosis, and even hypokalemia. Okay, so what was the exact question? I like perfectly nobody could able to tell me what was the exact question, but yes, definitely the chloride channels are involved up, and this particular CFTR channels are there. They open up, and there is a chloride and SCO3 which comes into the lumen, and because of that only, the massive rice watery diarrhea happens up in the patients. Okay, so if you want up all this images and all, so I will provide up also. Now, other than this, guys, some one-liners type, which I able to get up that this question was there. The condivectin diphtheria, the diphtheria toxin, which is termed as the a very strong exotoxin. And I used to tell up this mnemonic to you that it have two parts, A and B. Condibacterium diphtheria is the one, and it acts on the elongation factor. Which elongation factor? Elongation factor 2. Yes or no? Elongation factor 2, EF2. So this is what is the action of this, and finally what happens? Inhibition of protein synthesis, and thereby inhibition of the protein synthesis leads to cell death. This is what is there. So A and B, two components. B helps in binding. A does ATP ribosylation of which particular thing? Elongation factor, and finally what happens? Inhibition of the protein synthesis, and thereby the cell death happens. In the HIV positivity, I think this question came that in HIV positive the diarrhea happens, and they have given up the size of the oocyst, and the oocyst size was mentioned 4 to 6 micron, and it was having a acid fast staining. It was like like quinone staining is being done now for this particular one. So I suppose this was also there in the EF2. It is EF2. Elongation factor 2 is the answer that you already know. Okay. So 4 to 6 micron for cryptosporidium parvum, and HIV positive. Obviously, this is the most common cause of diarrhea in the HIV positive, and having the oocyst size of how much? 4 to 6 micron. And you go for this modified acid fast staining, that is quinone staining for this particular one. And what they are coccidin parasites. That is the intestinal protozoa. Yes or no, guys? Other than that, if you see the notes and all, I mentioned up, which is the most dreadful complication of meningococcal meningitis. This is Waterhouse Friderichsen syndrome. And what is that? Bilateral adrenal hemorrhagic necrosis. Bilateral adrenal hemorrhagic necrosis. This is what is typically Waterhouse Friderichsen syndrome. Okay, along with that, if you're able to get a petechial lesions and all, that is what is termed as purpura fulminans. Okay, that is what is termed as purpura fulminans. I suppose this was also there in the exam. And if you have done my lectures and notes, must have done this correct. Waterhouse Friderichsen syndrome. Atur Rahman, it was there or not, guys? And what about this hereditary angioneurotic edema? They were telling up that they have given a picture of this particular one, and there was a swelling of the lips and all. And this is typically observed in what? Hereditary angioneurotic edema. And if you see up, I have mentioned up in the complement chapter that C1 esterase inhibitor deficiency is a causal agent of the same. Okay. So C1 esterase inhibitor deficiency is a causal agent of the same. So this was there. Yes or no? All questions from your notes only, sir. Okay, Dharmesh, thank you so much. And this was a slight bit new that they have asked up that GRDS's, the drug of choice is metronidazole as such, but they told that it is resistant to metronidazole. Then what to use? Then you have to use up that drug which is being used in the cryptosporidium parvum, that is nitazoxanide. Okay, nitazoxanide is there in the resistant cases of GRDSs. Yes or no, guys? So this also can be easily done. I don't know which particular thing came, congenital CMV came or congenital rubella came, But if it is being mentioned a blueberry muffin rash and all those particular ones, then obviously it is towards the rubella, congenital rubella, and that triad you already know. But exactly you can tell up Dharmesh what was asked in the exam. It was CMV or rubella, and what are the other features being given up. Okay. Then Zarelin. Zarelin. Okay. There was a picture and deafness was being told up. Okay. So what you marked, Dharmesh, that particular question? This particular question, what you marked? Is it congenital rubella or what? No rubella in option. Okay. In deafness happens in CMV also, na guys? In CMV also, this chororetinitis and hepatosplenomegaly, uh, jaundice. So all these are features of congenital CMV. So obviously it's going towards the congenital CMV. Sensory hearing loss is there in congenital CMV also. And what is the sample of choice for congenital CMV, guys? This might be for the future. The answer is what? Answer is urine. In the urine, you try to demonstrate what? CMV antigen. Okay. So Zarel Lynn strain was being asked, guys, and Zarel Lynn, I told you, Zeri's mom name is Lynn. If you have done my class, so mom's Zarel Lynn strain, and bilateral parotitis is the most common one, obviously more than the unilateral. Okay. 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 Fine. 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 And this, somebody was telling that Lyme's disease was asked, Borrelia burgdorferi, erythema chronica migrans, and doxycycline. What you marked up as the answer? Doxy or ceftriaxone? Somebody is still telling. What was the exact question and what exactly came up in the exam? That also you can tell up. That I will include in a proper recall of one. Okay. So erythema chronica migrans, you know, it is termed as bullseye lesions or target lesion and seen in Lyme's disease. And one more thing, if you remember in the class, you used to tell up that this particular disease have heart blocks. Okay. This particular disease have heart blocks, which is a unique thing, 1 degree, 2 degree heart blocks. Lyme's disease done by Borrelia burgdorferi and transmitted by what? A tick. Okay. This was their TB meningitis with obstructive hydrocephalus and all the features were being given up. And I suppose in one of the questions, if it is not the same, I don't know, but it was being given up low sugar, high protein. That analysis of the CSF was also being given up in the options. So obviously it is towards what? TB meningitis along with the, if the features are being given like papilledema and all, so it is towards the obstructive hydrocephalus. Okay. And type 2 Lepra reaction was also there, guys. Type 2 Lepra reaction, which hypersensitivity? So obviously the rule of 5, you know, 2 plus 3. That is type 2 Lepra reaction is type 3 hypersensitivity. Type 1 Lepra reaction is type 4 hypersensitivity. Okay. So other than that, any other thing which you want to add up to this, please tell me so that I can put up in the later on in the proper recalls for the future of future doctors, future junior doctors of yours. Okay. So this much is there. I think parasito have not come this time much. That is no egg picture and all is there. And in the immunology something came, sir? Immunology. In immunology something came, yeah? Like Acha. Bacteriological index was asked. Less than 2, more than equal to 2. Early detection test for diphtheria. That is meant. Enterovirus. Yes, this came question. That what is the one of the common causes of aseptic meningitis? So answer is enterovirus. So that is also there. Enterovirus. And I suppose there was a question regarding the hemorrhagic conjunctivitis also, if you remember up. Okay. Hemorrhagic conjunctivitis also there was a question. And what were the option of that hemorrhagic conjunctivitis, guys? If you remember, hemorrhagic conjunctivitis. And the things which I made you to remember, Coxsackie virus, A24, enterovirus 70. Were they in options or adenovirus was an option? What was given up in the option? Is it the adenovirus or Coxsackie virus A24 or enterovirus 70 was there in the big options? A picture was being given. Okay, next year. Picture was being given for this particular one. Okay, adeno was there, antero was also there. Oh. Acha. Then what you have marked up? Acha, both option was also there. What you marked up? Atur Rahman or Dharmesh? A trichophyton question I have already done. That is, it is anthropophilic. Rubrum, I think, have come now. So I've already covered Muskan, that particular one. Acha, Dino. That is there, no? That epidemic keratoconjunctivitis, that is there. That adenovirus 8-19-37 associates with that. Okay, also termed as adeno. Fine. Your answer is correct. So I suppose you have marked up all the correct answers in the microbiology, and very best of luck from my side. You achieve high, and very high ranks. High ranks in what sort? In top 100 side. Okay, and very best of luck from my side. And do tell me all important ones which I can integrate with this in the comment section and all. And very best of luck from my side, and achieve success, and best of luck from my side. Dharmesh. Okay, Muskan, Tharun, and do tell up your results. And I suppose it will be very good. Okay, so thank you so much. Take care. Bye bye. Yeah, and thank you, Doc. Lecture. Best of luck, guys. Take care.
Okay. Thank you so much. Thank you so much. Thank you so much for the things, buddy. We'll be starting the session. And as per Pharmac is concerned, we faced around on an average of around 14 to 15 questions. But again, as we know in this exam, we have lots of integrations from medicine and also from the other subjects too. Lots of pediatric integrations, lots of psychiatry integrations, and of course, three major questions from opioids. The weightage was a little bit different because usually we have some high yield topics. Instead of these high yield topics, they have deviated a little bit. But it is not going to be affecting a lot because even though they are not targeting the high yield previous year topics, they were targeting more on your basics. They are targeting more on your mechanism and the core pharma questions. Okay, that's the basic analysis of what has happened for today. We'll be starting with the first question. Just give me a minute. Yeah, we'll be starting with the first question. As we can see, this is the first question, buddy. A patient with symptomatic chronic heart failure. A patient with symptomatic chronic heart failure is prescribed vericiguat. What is the mechanism of action of vericiguat? This was the question. Okay, symptomatic chronic heart failure is prescribed vericiguat. What is the mechanism of action of vericiguat? This question is somewhat easier because we have discussed it already. Again, GUAT stands for guanylyl cyclase activator. GUAT stands for guanylyl cyclase activator. As much simple as that. And from that, we have one basic option, which is directly activates soluble guanylyl cyclase independent of nitric oxide, releases nitric oxide, which activates the guanylyl cyclase. The other option includes stimulates soluble guanylyl cyclase, enhances its sensitivity to endogenous nitric oxide, and inhibits phosphodiesterase 5, thereby increasing cyclic GMP levels. This option D is very much clear cut. It is for sildenafil, so it is not going to be involved over here. And we have option C. Option C is soluble guanylyl cyclase, but again, if it is activating guanylyl cyclase, it is not going to be further stimulating the nitric oxide levels. So that is also getting ruled out from this. Yeah, 1 minute. 1 minute. Yeah. So that is also getting ruled out. So primarily, we are there in a primary mishap between whether it is option A or option B. See my dears, guanylyl cyclase is there, no? Guanylyl cyclase is activated by nitric oxide. Guanylyl cyclase is activated by nitric oxide. So usually what we do, we administer certain set of drugs like nitrates, nitrites, or nitroprusside. These drugs will be releasing nitric oxide, which in turn will be stimulating the guanylyl cyclase. So that is the primary mechanism of nitrate. So if the question is regarding nitrates, then the answer would be releases nitric oxide, which activates guanylyl cyclase. If the question is regarding nitrates, then the answer would be that. But the question is not regarding nitrates. Instead, the question is regarding VC-GWAT, and that's why the answer here is directly activate soluble guanylyl cyclase independent of nitric oxide would be the best answer for this question. Because these drugs are structurally very much similar to that, it will go and bind with guanylyl cyclase directly and tend to stimulate it. We have Rio-C-GWAT, we have Rio-C-GWAT, and we have VC-GWAT. Rio-C-GWAT and VC-GWAT, these drugs are primarily being used for pulmonary hypertension. And this is what we have discussed in our own sessions, buddy. As we can see, we have discussed it very much clearly. Guanylyl cyclase activator, VC-GWAT, and Rio-C-GWAT. These are the drugs which are used, actually been primarily approved for pulmonary hypertension. It has also been approved for heart failure too. So this is the mechanism of action of that particular drug. First question is done. Moving on to the second question. So here we have a known case of substance abuse is brought to the emergency department with respiratory depression, bradycardia, hypotension, and pinpoint pupils. Which of the following is the most appropriate antidote? And I'm hearing certain statements like the statement of opioid toxicity itself has been there in the question. Whatever be that, because if it has been suspected as opioid toxicity, there is no need for the clinical scenario actually. So even if it is going to be there, we are very much happy because this question is regarding opioid overdose. Opioid overdose, the answer for this question you would have read regarding naloxone. Of course, naloxone IV, it has to be administered as multiple IV. It has to be administered as multiple IV because naloxone has got a very short half-life. So when you administer naloxone as IV, immediately after that patient is actually in respiratory depression. They might be landing up in, I think it has not been given up here. They might be landing up in loss of consciousness too. So patients might be in coma and a patient might be slipping onto unconsciousness, and you administer this your naloxone, and the patients will be waking up back. Again, they will slip into coma, right? Because the effect of the drug will not be long lasting. It has got a very shorter duration of action. So it has to be administered as multiple IV boluses. It has to be administered as multiple IV bolus. That is the first line therapy of choice. Most of the students were not having any confusion here, but they were having some confusion. So what if it is naltrexone? Naltrexone is not been used as a first line therapy for opioid toxicity. Naltrexone has been used for alcohol de-addiction. Well, that has been the first line therapy there. For opioid toxicity, we need to have a drug which has got a rapid and a quicker onset of action. So we prefer to go for naloxone. Okay, as we have seen here, this naloxone is being used. This is an antagonist which is used for opioid toxicity and has got a short half administered as multiple IV bolus. It has got a very poor per oral absorption. That's why it is always administered as IV route. Okay, we have finished the second question. Moving on to the third question. Third question, this is one of my favorites, no? Like, why? Because it's one of my childhood. I have been discussing about this question since like 2 years of time. At last, I'm happy to see that this question has been asked in our exams. So a patient with psychosis has been receiving clozapine therapy, and he's a known smoker, and he stopped smoking 2 weeks ago. And since he developed 2 episodes of seizures per day for the last 2 days. Which of the following best explains the relationship between smoking cessation and the development of seizures? I hope that this is taken up from our notes, my dears. As we have discussed already, cigarette smoking is actually, cigarette smokers are microsomal enzyme inducers. Cigarette smokers are microsomal enzyme inducers, though they will induce the microsomal enzyme, which is responsible for the clozapine's metabolism to happen. Okay, now what happens whenever the patient is stopping to smoke? What happens? The microsomal enzyme induction is not going to be there. So there is no concept of clozapine getting metabolized, and you have to, the dose which you administer, the clozapine might get accumulated, and the patients might land up in agranulocytosis, or as an acute therapy, they might land up in seizures too. So to prevent the development of seizures, what you have to do? Patient is under clozapine therapy. He is a chronic smoker. He decides to quit smoking because smoking itself is a risk factor for psychosis. We all know that. Acute psychotic episodes, smoking is a risk factor for it. So when the patient is deciding to quit smoking, we have to make sure that the clozapine dose has been decreased by up to 30%. Yeah. It is taken up exactly from our notes, and that is what the answer for the question is going to be. The answer is smoking cessation decreases CYP1A2 induction, increasing clozapine levels. Well, that is the answer for the question. Okay, so what about the other options? Smoking cessation increases CYP1A2 activity. No, it is completely wrong. It is not going to be, smoking is going to be inducing. Smoking cessation will not be inducing that. Smoking cessation has got no effect in clozapine metabolism. No, smoking will be increasing the clozapine metabolism. Smoking cessation increases clozapine metabolism. No, smoking increases clozapine metabolism. Smoking cessation will decrease or will prevent the clozapine from landing up in metabolism. So the better answer for the question is going to be option B. Good, guys. Moving on to the next question. A patient under total intravenous anesthesia was administered an opioid with extremely rapid onset and offset of action. Its metabolism occurs mainly through non-specific plasma esterase. Which drug is most likely being used over here? Okay, this question is regarding a drug which has got a shorter duration of action. Students were very much clearer that sir fentanyl was the drug. Yes, sir, remifentanil was the drug because it was already been there. Remifentanil, as we have discussed it already, just give me a minute. It's not really, yeah. As we have discussed already, remifentanil is an ultra short acting drug because it is an ester drug. It is quickly broken down by the two powerful enzymes. Remember that? Esterase and peptidase enzymes. Yeah. So esterase and peptidase enzymes. So this is broken down by the esterase enzyme. That's why it has got an ultra short duration of action. But students were landing up in, sir, what about, I know that it's remifentanil, but when I looked into this sufentanil and fentanyl, I land up in confusion. No need to worry about this. The ultra short acting drug is going to be remifentanil. That's the reason why it is being used for breakthrough episodes in terms of cancer pains. Patients who are under cancer related pains, they will be under long standing therapy with a longer acting opioid drug. And when a patient is suddenly, when the patient, even if the patient is taking up a longer acting drug, suddenly there might be breakthrough pains. And for the breakthrough pain, the treatment of choice is going to be administering remifentanil. We should not increase the dose of methadone or long acting opioids. We have to just administer remifentanil. All these things we have explained during our sessions. Well, that is the answer for the question here. So for this rapid acting and rapid onset and offset of action, answer is going to be remifentanil. Moving on to the next one, guys, we'll be treating it very much shorter. Don't worry, I have not been explaining a lot of about this. This question, what is the mechanism of N-acetylcysteine? Well, this was easier when you looked into the question as N-acetylcysteine, because we all know it is glutathione replenishment. But how it is going to be doing that? Well, that's what the question which has been asked here. Well, for the management of productive cough, well, that was the question. It is not about paracetamol poisoning. Instead, they shifted on about N-acetylcysteine and its use in productive cough. Because we know, we have heard about this particular terminology that N-acetylcysteine is a mucolytic agent. How it is going to be lysing out the mucus? Simple one. In both of these areas, be it paracetamol poisoning or be it for productive cough, it is going to be a sulfhydryl donor. This drug is a sulfhydryl donor. Whenever it is donating those sulfhydryl, yes, logical 715, good number for you. It's a mucolytic agent, yeah. When it donates the sulfhydryl group, it is going to be producing breakage of the disulfide bonds. Well, that's the reason the answer for the question is breaking the disulfide bonds of the mucus. Sir, when I read this option, no problem at all, but I got a confusion when I moved into the option D, breaks glycopeptide bonds in the mucus. Yeah, it is not going to be a peptidase. N-acetylcysteine is not going to be a peptidase. It's a cysteine molecule. As we know, cysteine molecules are going to be breaking down the disulfide molecules, and that's why the answer for the question is going to be breaks disulfide bonds in the mucus. Only one option was there related to mucus. Okay, is that so? But okay, if it is so, no problem at all. If it is only one option was there, no, there is no worry. There is no need for any glycopeptide bonds query is not going to be there. But if glycopeptide is there, no need to worry. The answer is again going to be disulfide. I thought that was the distractor. I hope happy to see that distractor was not there in the question. Okay. Acts as a glutathione donor. See, here is where one interesting question is there. Acts as a glutathione donor. It is not going to be donating glutathiones, right? It's going to be like increases the glutathione concentration inside those liver. Well, this is the mechanism. Nearby, this is the mechanism for paracetamol poisoning. It is not the mechanism for the mucolytic mechanisms. Suppresses central cough center. This is again drug which is gaining entry inside the brain and suppressing it, which is your opioid drug like codeine drug. No, codeine is there, dextromethorphan is there. This drug will be suppressing the cough center. Well, this is not a question regarding dry cough. This is a question regarding protective cough, and that's why this option is also going to be ruled out. Okay, buddy, as we can see, we have discussed about N-acetylcysteine, carbocysteine also under protective cough. As we know, this drug, as I think Logical 75 was explaining, we were talking about it as a mucolytic agent. And moving on to the next question, this is more of a micro and a medicine related question, I suppose, but anyhow, pharmacologically, we have been explaining that multiple times. A patient with giardiasis has been receiving metronidazole but shows no clinical improvement even after 3 days of treatment. Which of the following drugs can be used as an alternative? So this is a case of resistant giardiasis. This is a case of resistant giardiasis. Yep. So what is the treatment of choice for resistant giardiasis? Yes, as we have discussed it already, resistant giardiasis, the answer is going to be nitazoxanide. Not only that, even for cryptosporidium, the answer is going to be nitazoxanide. Cryptosporidium, and also for resistant giardiasis, the answer would be nitazoxanide. And we can see here the answer is going to be nitazoxanide. Yep. No glycopeptide option was there. Okay, thank you, Rahman. I hope that if it is not there, very much happy. That is not for actually that is practically there is no distractor there. Okay, moving on to the next question, buddy. 60-year-old, okay, a 60-year-old was administered mirabegron for her urinary urgency. Which of the following best explains the mechanism of it? This is a direct question. Thank you, Venki. I think glycopeptide was not there. Thank you so much. Which of the following best explains the mechanism of this mirabegron? As we can see, this is our sessions where we were discussing about what's the concept, what's the treatment for overactive bladder and treatment for postoperative urinary retention, POR and OAB. Nifurtimox was there, but nifurtimox is not going to be the answer in that question. The answer is nitazoxanide. Okay. See, we have the present treatment of choice for, just note it down. If metronidazole is not responding, the next best treatment is going to be nitazoxanide. But if in case you cannot administer nitazoxanide, then we have to give a combination therapy of albendazole and metronidazole. We'll go step by step also. I have explained the next step also. If the patient cannot be administered nitazoxanide, if nitazoxanide is not available as an alternative, we can also administer albendazole with metronidazole combination. That also will work in certain cases. Okay. So here we'll come back to this overactive bladder and postoperative urinary retention. As we can see, beta-3 receptor agonist agent, we have two drugs, mirabegron and vbegron. Mirabegron, 1 minute. Yeah, mirabegron and vbegron. And also we have one more point. Mirabegron is also associated with angioedema. That was the reason why we designed vbegron, the second drug. So the answer is very much simpler. This is a beta-3 adrenergic receptor agonist agent. It is not an antagonist, because of course if it is an antagonist, the drug name is going to be somewhat around LOL drug. No, it is not an LOL drug, so of course it's an agonist agent. It has got no relationship with the muscarinic. As we can see here, they have given you this as a distractor, muscarinic receptor antagonist. We can use muscarinic receptor antagonist also, but muscarinic receptor antagonist is not mirabegron. If the question contains solifenacin, then the answer would be M3 receptor antagonist. Or if the question contains darifenacin or trospium, then the answer would be M3 receptor antagonist. But the question clearly contains mirabegron, so the answer is going to be beta 3 receptor agonist agent. Fantastic, guys. Moving on to the next question. Okay. Which of the following drugs is used in the management of tumor lysis syndrome in a patient with CKD? Tumor lysis syndrome in a patient with CKD. Okay, I heard this question was there. And see, first of all, tumor lysis syndrome, the concept here is whenever there is breakdown of the nucleic acids, there will be accumulation of uric acid inside the body. And this uric acid has to be let out from the body. So the drug of choice for tumor lysis syndrome would be rasburicase. But students started explaining that, sir, it was good, but until we heard this particular terminology, what about CKD, sir? Chronic kidney disease, can we give this drug or not? Okay. See, the point is, in chronic kidney disease, the drug of choice is going to be rasburicase, because if a patient is presenting with chronic kidney disease, okay, chronic kidney disease, and you plan to administer allopurinol, you know what happens? Chronic kidney disease and you administer allopurinol, patients might land up in allopurinol hypersensitivity syndrome. The drug might get accumulated. And that's why in terms of renal failure, we have to decrease the drug dose of allopurinol. Rasburicase, there is no need for drug dose modifications as per your renal failure is concerned. Okay. Question was, which drug was most effective to reduce the uric acid levels? Actually, the answer is rasburicase, but I will tell you why this statement. I'm getting option Benki saying that which drug is more effective to reduce the uric acid levels. You know what? Because when a patient is presenting with the tumor lysis syndrome, you know what is the best treatment of choice for that? It is going to be fluid. Give the fluid for the patient, increase the urinary output, uric acid will automatically come out. Okay, that will be the primary treatment of choice for tumor lysis syndrome. So as for decreasing the uric acid levels, as a hypouricemic agent, only rasburicase will be the treatment of choice. Okay. So the question, we know why they have given that in the question. It's because they just want to make sure that we are not asking the first line therapy. We're asking for the drug which is going to be decreasing the uric acid levels. To understand that only, they have given that particular statement in the question. I hope this answer your query, Venki. Yeah. So the answer for the question is clear-cut rasburicase. Allopurinol cannot be given. We have to decrease the dose in terms of renal failure. Even though we can give, but we have to decrease the drug dose. But a safer alternative would be rasburicase. That will be the first-line therapy of choice as a hypouricemic agent in tumor lysis syndrome. And primarily, I will tell you one more point. Allopurinol usually is not been preferred for tumor lysis syndrome because allopurinol will just decrease the further synthesis of uric acid. It will not decrease the pre-existent increased uric acid levels. Already there is increased uric acid accumulated inside the blood, no? That will not be working up over there. Okay, Atur Rahman was saying furosemide was there in the last option. Okay, furosemide was there, but you know what? I will take out this furosemide immediately. Why? Because furosemide is a loop diuretic. These drugs itself will induce hyperuricemia. Diuretics will be inducing hyperuricemia. We cannot give it, even though it is more easier for us. When you think about CKD, you always think about furosemide, but it will not be the answer there because furosemide is a diuretic agent and it might produce hyperuricemia. That's why it is going to be exactly ruled out. Okay, answer is option A by this. As we can see here, we have discussed about rasburicase. Of course, it's going to be there in all of the sessions. It's a very important question for that also. Moving on to the next question. Okay, this is one of the most brilliant questions to be answered. See, a patient with acromegaly is receiving octreotide. On follow-up, he found to have persistently elevated IGF-1 levels. Which of the following drugs most appropriate for further management? Yeah, I hope this question was there in your exams. I hope, on a minute. This question was there in your exams. Please put up what exactly was the answer which was given up to you. Yeah, you know what? There are lots of small things are there in this question. Okay, just by a single statement, the total answer is going to be entirely different. Okay, I will tell you one thing. You know what? What is the decision making here? Patient who are presenting with octreotide. Octreotide is a somatostatin analog agent. It is a somatostatin analog. Yep. Octreotide, whenever it is administered, we can also go for lanreotide. Either octreotide or lanreotide or pasireotide can be given for acromegaly. But whenever a patient is not responding properly, okay, whenever you have to look for the circulating IGF-1 levels, just look at the circulating IGF-1 levels. Okay, we have two major options. When the patient is not responding to octreotide, almost same stem, good. So when the patient is not responding to octreotide, we have to look for the serum IGF-1 levels. Okay, serum IGF-1 levels, it might be normal or serum IGF-1 levels will be raised. We have two different stages where the serum IGF-1 levels might be normal, but the growth hormone is going to be increased. Growth hormone levels is entirely different. Here we are talking about IGF-1 levels. Based on this, if IGF-1 levels are normal, you know what is the best drug to be added? We have to add cabergoline. Cabergoline will be the treatment of choice in those conditions, because this is the drug which will not decrease your IGF-1 levels. That drug will be decreasing the growth hormone levels alone. Okay, whereas vice versa, if IGF-1 levels are getting raised, then we have to add pegvisomant. We have to add a somatotrop antagonist agent, which is your pegvisomant. Okay, see, the point here is cabergoline will be decreasing the growth hormone levels. Okay, will be decreasing the growth hormone levels. It will not decrease the IGF-1 levels, whereas pegvisomant will be decreasing only the growth hormone levels. Actually, you know what, as a vice versa, there is going to be increasing growth hormone levels. There might be a constant increase in the growth hormone levels. Rarely pegvisomant might increase the growth hormone levels as a reflex mechanism. It might increase the growth hormone levels, and that's why we have to regularly monitor the development of any adenoma if a patient is having. If a patient is having an adenoma, there might be a possibility of increasing growth of that adenoma also when you add pegvisomant. Okay, Doppler was 5.5. I don't know what's that. Okay. Okay, Akshaya, good. So here the increase in growth hormone levels, please note it down. Here the answer is going to be pegvisomant. Here the answer is going to be pegvisomant. If the statement contains the IGF-1 levels are normal or near normal, growth hormone levels are raised, then the answer would be cabergoline. Here the IGF-1 levels are raised, so the answer is going to be pegvisomant. Fantastic, good. As we can see here, pegvisomant is a growth hormone receptor antagonist. It will block one growth hormone receptor antagonist, preventing the remember that? Yeah, remember the clap in the hands? Yeah, preventing the homodimerization, thereby decreases the IGF-1 levels. That's the way in which pegvisomant is going to produce it. See, if it is blocking the receptor, what do you expect the hormone level is going to be? Hormone levels is not going to be controlled. Instead, there might be, usually it will not, but there might be an increase in the growth hormone levels. Fantastic, guys. Moving on to the next question. Again, this is they have given an image in the exam. This is an IBQ. In the arachidonic acid pathway, they have given an enzyme which represents phospholipase A2 and B represents cyclooxygenase enzyme. Which of the following statements is correct was there in the question. I don't have the image. Instead, what I did, I took up that image from our notes itself, because this everything is going to be same. As we can see, this is your cell membrane is there. Whenever there is stress or infection from the cellular membrane, there will be production of two major enzymes. One is phospholipase A2 and NF-kappa B. Because of phospholipase A2, arachidonic acid will be synthesized, and arachidonic acid will be converted to prostaglandins by the cyclooxygenase 2 enzyme. As we have seen, steroids will be inhibiting phospholipase A2 and NF-kappa B. Steroids will be inhibiting phospholipase A2 and NF-kappa B, whereas NSAIDs will be inhibiting cyclooxygenase enzyme. As per inflammation is concerned, primarily targeting cyclooxygenase 2 enzyme. So here the answer, I will give you one more sentence. Adenosine can be used as an inflammation, used for an anti-inflammatory agents, because it is also decreasing NF-kappa B. The same diagram which we have taken up from our notes itself body. So that's why the answer for the question is, if A represents PLA2, B represents cyclooxygenase, steroid will inhibit A, NSAIDs will inhibit B will be the answer in this question. Yeah, I hope this question was there in the exams body. If it is there, please drop a message. Yes, it was there. A similar image was there. I'll be very much happy to hear that. Okay. Yes, moving on to the next question. A 32-year-old man, with bipolar disorder is started on lithium therapy around 900 milligrams per day. At a follow-up visit, he reports mild tremor of his hands but has no ataxia, dysarthria or altered sensorium. Which of the following statements regarding lithium is correct? Well, that is the question. Thank you, Ashik. Thank you, Arun Hamza. I hope that if the question was there, very much happy. And now about lithium. So we have fine tremors can occur at therapeutic doses, tremor occur at only at toxic doses. Lithium does not cause tremors, and tremor are always associated with lithium-induced ataxia. See, this question, first of all, I got a lot of students asking up to me saying that, sir, it was given 900 milligrams per day, and I thought it was toxicity symptoms, and I went with tremor will occur at toxicity doses, and I went with that particular option. Lots of the students went off with that. Okay, so 900 milligrams, they thought it was a high dose. No, 600 to 900 milligrams per day in 2 to 3 divided doses is the normal dose of lithium which we use for bipolar disorders. It is not a high dose, it's a normal dose. Okay, so here we have to think about lithium does not cause tremors is getting ruled out. This lithium does not cause tremors is getting ruled out. Lithium will cause tremor. Tremor always associated with ataxia. No, tremor can be separate. Ataxia can be separate. Tremor occurs only at toxic doses. Actually, coarse tremors will occur at toxic doses, whereas fine tremors will occur at therapeutic doses. Yeah, coarse tremors was mentioned in the question. Okay, if a question contains instead of mild, there was coarse tremors was mentioned in the question. Okay, Nafishat. Okay, if any other changes are there in the question, please put up in the chat box. Okay, so coarse tremors was there in the question. Whatever be there in the question, I think if the options are somewhat nearby, then the answer is going to be fine tremors can occur at therapeutic doses would be there. Because it happened, sorry, it's therapeutic levels, because it happened after gastroenteritis. It was given like that. It was given about gastroenteritis. Extrapyramidal effects are actually after an episode of gastroenteritis. Sodium loss can cause lithium toxicity. Yes, buddy. Because of gastroenteritis, when a patient is landing up in hyponatremia, there will be reflex increase in the lithium absorption from the proximal convoluted tubule, because of which patients might land up in lithium toxicity. So if a question is regarding any of this, regarding if a question is, if the statement contains after gastroenteritis, or after an episode of hyponatremia, if anything is there in the question, there might be a possibility of toxicity symptoms. Okay, there might be a possibility of toxicity symptoms, but again we have to look at the options. Just fine tune the options. But if are these options right? Are these options right? 50 milligrams some drug is given along with this. Is that so? I think Phoenix is saying that 50 milligrams some drug, some other drug also was given along with this. Yes. 50 milligram quetiapine was also administered. 50 milligram quetiapine was administered for this patient also. Quetiapine and lithium, the most common combination drug which we give as a first line therapy for bipolar disorders. So lithium is given along with quetiapine. Lithium is given along with quetiapine. Okay. Along with quetiapine 50 milligrams. Okay. Along with quetiapine 50 milligrams. Okay, what about the options? What about the options? Because just by looking at the options, we can come up with the answers. If the options has been framed up correctly, the answer is again going to be A. Was A will be the option. Lithium-induced tremors at therapeutic levels. Yes, this is there. This option was there. Fantastic. First and second option was there. Okay, first and second option was there. Fantastic. And we had a thing called as lithium toxicity. Lithium toxicity was there in the option. Okay. Option C was lithium toxicity. Okay. What about option D? Option D was there. First two were there. Okay. If first two were there, of course, this is the question is regarding, again, I would just want to ask one more question. Was it a positive phased or negative phased question? Was it a positive phased or negative phase? Which means they're asking lithium is correct or false statement. They're asking correct statement or false statement. Correct statement or false statement. Which of the following is incorrect or which of the following was correct? EPS are most common side effect. They quote extrapyramidal side effects are most common side effect. Extrapyramidal side effects will not be that much seen with quetiapine, but quetiapine is an atypical antipsychotic. So usually it will not produce extrapyramidal side effect. Question was a positive phased question. Yeah, question was a positive phased question. Then the answer is going to be option A, buddy. Then the answer would be option A. They have given certain other clinical scenario also in the question, which is correct. They ask, fantastic, Shashank. Thank you so much, Afzal. Thank you, Afzal. Thank you, Arun. Thank you, Shaka, Vengi, Nafisat. Thank you, Phoenix, Hemkumar. Thank you for giving up this. Yeah, option A is the correct option then. Okay, I think they have given lots of mix-ups in the question, but whatever be the mix-ups in the question, the answer is going to be option A. They have given lots of previous year questions, no hyponatremia. They have given a case of gastroenteritis also. Okay, as we can see here, adverse effects, fine tremors, we have discussed already. Coarse tremors, it was a separate thing. Coarse tremors in terms of toxicity symptoms, fine tremors even at the therapeutic levels itself. Okay. Moving on to the next one. Okay. This question, a 45-year-old man with heart failure has been taking spironolactone for the past several months. He presents with DH Saka, if I'm pronouncing the name right. Thank you. So it was a tricky question. He presents with progressive bilateral breast enlargement for the last 3 months. He is suffering from gynecomastia. He is suffering from gynecomastia. Which of the following mechanisms is primarily responsible for this adverse effect? So this is regarding spironolactone induced gynecomastia. They are asking about the mechanism of gynecomastia. Option A was direct inhibition of androgen receptors. Option B, direct stimulation of estrogen receptor, reduction in testosterone, reduction in circulating estrogen levels. Was this question asked, buddy? Was this question asked? I heard that this question was being asked, but again, some students were skeptical about, so I don't know whether this question was, I faced the question or not. Was this question asked? Yes, yes, thank you. Thank you. This question was okay. Very good. So this is regarding spironolactone and its gynecomastia. Okay, and associated gynecomastia. Now the simple point is spironolactone is an aldosterone. Yes, buddy. It is an aldosterone. It's an aldosterone receptor agonistic drug. Okay, it's an aldosterone receptor antagonistic agent. This drug structure is very similar to aldosterone, and that's why this drug name is ending with "on." Everything is there in the sessions itself. Spironolactone is been derived from the structure of aldosterone. It's a sexual hormone, and thereby it will be having two important mechanisms of how gynecomastia is getting developed. Okay, two mechanisms of gynecomastia. Number one, it will be blocking up the androgen receptors. It will be blocking the androgen receptors, and number two, it will produce displacement of estradiol. Displacement of estradiol from the sex hormone binding globulin, from the protein binding. Okay, two important mechanisms are there. Number one, blockade of androgen receptors, and number two, displacement of estradiol from the proteins. These two mechanisms are there. Did we see any question regarding, did the options contain estradiol, buddy? Please help me out. Did the options contain, because I'm having a confusion of whether there was any question regarding estradiol, like levels of estradiol is getting increased. Was it there in the options? If that was there in the options, then then there will be a lot of confusion in the answers. Was there any options of increasing estradiol concentration in the blood? Was it there in the option? Can you recall? No, it was not there. It was not there. There was no option of increasing or increased concentration of it. It was not there. Prolactin levels increase A beta option. Okay, prolactin level has got no relationship with this over here, my dears. No estradiol was mentioned. Estradiol was not mentioned. Then no problem at all. Then there is no. I was having a major query because two mechanisms are there. I don't know which they were actually asking about. So estrogen receptors. No, it was not there. Okay. So this question is getting ruled out. This option is getting ruled out. Reduction in testosterone synthesis. No. If testosterone synthesis is getting reduced, it might be a reason for it. But here it is not about testosterone. It's going to be the direct blockade of androgen receptors in the periphery. So the answer for this question is direct inhibition of androgen receptors, not direct stimulation of estrogen receptors. It will not bind with estrogen directly. It will prevent the androgen receptors. But you know what? What if this option, no? If this option, no, option B, direct stimulation of estrogen receptor, if it has given indirect stimulation of estrogen receptor, if indirect stimulation of estrogen receptor was given in the options, I will take that option. Okay, I will take both of these options as the answer. Okay, because if indirect stimulation of estrogen receptor, because by displacing estradiol, it might go and stimulate the estrogen receptor. That might be a possibility. But again, I think if it was not there, no, first option is there only. Okay, then the answer is better. Answer would be option A, direct stimulation or direct inhibition of androgen receptor. Yeah, answer key PDF will come. Kirtana, I think we are expecting like it will be giving within one week of time. We have to wait till that now. Yes. Okay, moving on to the next question, buddy. Next question, I think this question is one of our favorite questions. So our students would be so happy on seeing that question again. Because a 32-year-old woman who was under therapy with oral contraceptives was diagnosed with TB, started on anti-TB regimen, following which she landed up in an unintended pregnancy. What might be the most probable reason? Remember that story? This was the same thing which I have taken out from our session. The same question has been repeated back in different words. This is the question. A female taking oral contraceptives acquired tuberculosis. After prescribing anti-tubercular therapy, physician advised the patient for alternative contraception. What is the probable reason for the advice? The answer for that was rifampicin increases the metabolism of oral contraceptives. I hope you remember that. I was talking like you are there in the OPD, patient is diagnosed with tuberculosis. You administer HRZT for the patient and the patient is taking OCP. Yeah, grabs Priyanka Chopra, yes. So the patient was taking oral contraceptives before and after 2 months the patient reports back that the patient is pregnant and you are the reason for it. You remember that? Yeah, you are the reason for the pregnancy, not directly, indirectly you are the reason for the pregnancy. The same things which she said in the classes, I'm just repeating back here. I hope that is going to be deja vu for you all. Okay, the answer for the question is rifampicin. Option B, induces CYP enzymes, thereby increasing the metabolism of contraceptives was the answer for the question. Okay. Moving on to the next question. A patient receiving morphine for chronic pain develops constipation. Which of the following drugs is used for long-term management of opioid-induced constipation? Guys, I just need your input from this question, buddy. Was this statement long-term management there in the question or not? Please help me out. Was the statement long-term management was there in the question or not? Because this particular statement will give a different answer. The answer is going to be entirely different. If long-term management was not there, then the answer is different. If long-term management was there, then the answer is going to be different. That's why I just want, anyone can recall what has happened during the exams? No. Venki says no, it was not there. Long-term management was not there. No long-term. Hemma says no long-term. Is it okay? Okay, no long-term. Thank you, Venki. Okay. So if long-term management was not there, then the answer is, better answer would be albumopan. Okay, naltrexone option. Yeah, naltrexone was given. No? Yeah, that's what methyl naltrexone is there. Okay. Immediate relief was asked. Okay, immediate relief was not long term. Immediate relief was asked. See, the point here is we have certain drugs which are named as peripherally acting mu opioid receptor antagonists. Peripherally acting mu opioid receptor antagonists. These are actually, if our sessions, our students know, recently I think we were explaining in the last few sessions. These drugs are named as PAMORAs. Okay, these drugs are named as PAMORAs, right? These are called as PAMORA drugs. These PAMORA drugs are peripherally acting drugs which are primarily being used for opioid, to prevent the opioid adverse effects from happening. Okay, adverse effects from happening. The point here is for this albumopan, methyl naltrexone, these drugs are called as PAMORAs. We also have naloxegol, lots of other drugs are also there. But if the question is regarding long-term management, then the better answer would be methyl naltrexone. That is the first line therapy of choice. Okay. Albumopan can be given for it. But please remember that it is not been US FDA approved for managing opioid-induced constipation. Albumopan is not FDA approved. It is not FDA approved for opioid-induced constipation. It is approved only for post-operative ileus, post-operative paralytic ileus. Only for that albumopan has been approved. So this question is little bit, we need more information on the question. Which drug can be given for the patient? Is it albumopan or methyl naltrexone? If methyl was not there, just naltrexone was there, at least tell me. If only naltrexone was there or methyl naltrexone was there, can anyone help me out with that? History was there, she was on chemo taking opioids for pain. Okay, chemo taking opioids for pain. Okay, chronic pain and she's under constipation. Okay. The question here is, was there methyl there in the options or not? or only naltrexone was there? Buprenorphine, Phoenix, only naltrexone was there. Rahman says naltrexone. Good, thank you, thank you. If only naltrexone was there is no confusion at all. The answer would be albumin. If only naltrexone was there, then the answer would be albumin. But if in case there was methyl naltrexone, then I will choose for methyl naltrexone. I will choose methyl naltrexone. Why? Because albumin is a drug, no? It has got a high risk of MI. Patients might land up in death because of albumin, and that's why it is not been advised to be given for a longer duration of time. Carries a bigger risk of adverse effects, and that's why methyl naltrexone will be preferred. If methyl is not there, then albumin will be the answer. Okay, good. Moving on to the last question for today. Yeah, last question for today for pharmacology. A patient with severe aplastic anemia is not eligible for stem cell transplant. Which combination can be used as an advanced medical treatment strategy? Buprenorphine was there. Ashik, buprenorphine was there in the options, right? Okay. So in the previous question, I think buprenorphine was there. Buprenorphine itself is a partial agonist. It will also induce constipation. Buprenorphine itself is a partial agonist agent. It will also induce constipation. We have to give a peripheral drug which is blocking the receptors. Pamora drugs are the drugs which has been approved. Methyl naltrexone is given. Actually, you know what? If, for example, I'm saying for acute therapy, acute treatment, if the question says give any like fiber-rich foods, it was there like anything regarding constipation therapy. Was it there in the option, buddy? Anything regarding fibers or like fiber-rich food, or anything regarding psyllium, anything which is related to drugs used for constipation, anything which is related there in that option? Or all the drugs were related to only opioids? There was no drug which is no option regarding fibrates and all. Diphenoxylate was there. I'm getting options. Diphenoxylate was there. Diphenoxylate was there. Okay, so there was no question, no options regarding diphenoxylate was there. Okay, so there's no fiber related or psyllium or anything related to that. No, that is, if it is not there, you know what? The first line therapy of choice is going to be having a fiber rich food, right? Just add Softovac. We had a brand name called a Softovac. No, we can just increase the fiber. That will be enough. Or we can increase the fluid intake. That will be the primary treatment. If a patient is not responding to that, then the better treatment would be administering a Pamora. Peripherally acting mu-opioid receptor antagonist agent. There we prefer to give methyl naltrexone, or we can go for oral naloxegol. But usually if methyl naltrexone is not there, then the answer would be albumin. Okay, Panchal, Ashik, Venki, Arun, thank you so much. We'll move to the last question for today. So severe aplastic anemia, actually it's not of pharmacology, it's more of medicine. Severe aplastic anemia not eligible for stem cell transplant. Not eligible for stem cell transplant, which is used as an advanced medical treatment strategy. The answer for this question is HATG, horse antithymocyte globulin with L-trombopag with cyclosporin. Okay, the question is very much clear. The better treatment, they're asking about advanced medical treatment. That's what there in the question. Advanced medical treatment means option A would be the answer. But what are the second line therapies, right? This is actually called as triple IST therapy. Triple IST, this is called as triple IST, means triple immunosuppressive therapy. Panchali, yes, option A was the answer. Yeah. Triple IST, triple immunosuppressive therapy combination, which is 1, 2, 3 drug is called as advanced medical treatment. We can also administer L-trombopag as monotherapy. We can also administer L-trombopag with cyclosporin. That is also there in the treatment. It will not come under advanced medical treatment strategy. Those drugs are second line therapy. If a patient cannot be administered HATG, only as a second line we can go for L-trombopag and cyclosporin combination. These are dual IST. Double IST or dual IST immunosuppressive therapy. So usually we don't prefer that drug. Here the answer for the question is option A, a combination of all these three. Lithium question had GI disease. Higashi, thank you so much. We'll be including that. Even if there is GI disease, they are primarily talking about hyponatremia, and we have discussed about that also. Viral blood transfusion, nobody. The treatment of choice here is going to be the combination of these three. Blood transfusion is not been given here. So in lithium, there was lithium toxicity. Okay, see, again, lithium toxicity options was there, but if, as I told, the first option, fine tremors are seen with therapeutic doses, if the statement was there, that statement would be the correct answer. Because the question is not which of the following is not why, which of the following is not correct. The question is which of the following is correct. So the answer is going to be that. Thank you so much. Thank you so much, Venki. Thank you. Thank you. I hope that we have did some help with answering those questions. We'll meet up. We'll meet up next time. All the best, guys. All the best for that. Bye bye. All the best, and please make sure you have a good sleep. Bye bye.
Is everything okay? Okay. So question number 1, which change is expected during a normal rightward shift of oxygen hemoglobin dissociation curve? So these topics are coming from NEET UG days. Okay. So they are asking about the concept. So whenever we are discussing this topic, we always discuss this point that the meaning of right shifting is what? The need of oxygen is more. You need more oxygen. You are needing more oxygen, whatever may be the condition. So when you need more oxygen, shift will be right. And when you need less oxygen, shift will be left. So you need more oxygen to reduce tissue oxygen delivery. No, you are needing more oxygen. So option A is wrong. Increase oxygen unloading to the tissue. Yes, true. Decrease oxygen unloading. No. Increase oxygen affinity. No. Reduce oxygen affinity. So whatever may be the condition, you are at high altitude, acidosis, pH is less, okay, or 2,3 DPG is more, increased temperature. Whenever there is right shift, we need more oxygen. So oxygen affinity will be less and dissociation will be more. So this was a direct question. Now question number 2, which is again a repeat question from INICT. Okay. Match the state of sodium channel during the action potential, closed, open, or inactivated. So this is a whole big topic which we have discussed in the chapter of action potential. If you remember, there are two gates of sodium channel. One is called as activation gate. This is called as activation gate. This was called as inactivation gate, and other name was M gate and H gate, or simply activation or inactivation. So during resting condition, when we are at the resting condition, okay, activation gate is closed, but it can be open. By the threshold stimulus, it can be open. Okay, so normally it is closed. So during resting condition, gates are closed. Okay, during depolarization, what happened? During depolarization, both gate activation as well as inactivation, both will be open. But during absolute refractory period, what happened? Okay, this channel remain open, but this channel will close. It is called as absolute refractory period or inactivated channel. This is a big topic. This is a very conceptual topic, which already we discussed. But please do remember, during resting condition, we will say channels are closed. During depolarization, the voltage gated sodium channels are open, so that sodium can come, causes depolarization, and after that they got inactivated. That is why we have absolute refractory period. Answer will be B. Clear? Then next question is about the intracellular recordings from a ventricular myocyte show a phase during which membrane potential falls steeply from approximately 0 millivolt towards minus 85 millivolt following a preceding plateau phase. So whenever we are discussing this topic, I always say there are two action potential in the heart. One is for the pacemaker potential, other is for the normal potential. One or two questions will definitely come in every exam. So this time they have asked about the normal action potential, not the pacemaker one. So we know this is phase 0, phase 1, phase 2, phase 3, and phase 4. So question is about which of the following best explain the ionic basis of steep repolarization phase. So it is asking about steep. This is early repolarization. This is late repolarization, or you can say steep repolarization. As you know, phase 0 is due to influx of sodium ion. Phase 1 is due to influx of potassium. 2 is also due to potassium. 3 is also due to potassium. But in the phase 2, during plateau phase, there is influx of the calcium. So calcium is coming inside, potassium is going outside, so it will cause a plateau phase. But question is about after the plateau phase. After the plateau phase, there will be late repolarization. So in the late repolarization is phase 3, inactivation of the calcium channel combined with increasing activation of delayed, see, phase 3, inactivation of L-type calcium channel. T-type, you know, they were in the essay note, combined with the increased activation of delayed rectifier potassium channel, producing a dominant outward potassium channel. So this is for, I mean, every year, INCT NEET PG, one or two questions are only from the cardiac action potential. This times questions are quite predictable because they were very important. Two questions were from Brown-Sequard syndrome. Like this first question is 22-year-old male after road traffic accident due to a fall from bike presents with left-sided loss of touch, motor paralysis in the lower limbs, loss of pain and temperature, crude touch on the right side. Now, in the Brown-Sequard syndrome or hemisection, there is contralateral loss of pain and temperature. So, the ipsilateral lesion will be on the left side. So, it will be, you can say, left lower lumbar hemisection. Okay, is this clear? Because we know in the Brown-Sequard syndrome, there is a hemisection of the spinal cord. And in the hemisection of spinal cord, which we called as Brown-Sequard syndrome, okay, what happened? There is contralateral loss of pain and temperature as well as crude touch. So because it is contralateral and it is on the right side, so lesion will be on the left lower lumbar hemisection. It is called as Brown-Sequard syndrome. Which of the following can be measured using the technique shown in the image? Plenty of time. We have discussed that spirometry cannot measure residual volume. Residual volume. Residual volume. Yes, doctor. The question was weakness of right leg and loss of. Okay, if loss of pain and temperature is on the left side, so answer will be right side. Okay, you are correct. If this must be the answer, I mean this will make the question, then answer will change. The main thing here is that it is contralateral loss of pain and temperature. If pain and temperature loss is on the right side, answer will be left. If that is on the left side, answer will be right. Okay, doctor? Now we know this cannot measure the residual volume. So it cannot measure also FRC. Okay, so it cannot measure also TLC. Why? Because TLC is vital capacity plus residual volume. FRC is what? What is FRC? FRC is ERV plus residual volume. So what is the answer? Vital capacity. You can measure vital capacity. Clear, doctor? Good. Now again, a patient after a head injury drinks 8 liters of water per day, has intense thirst, dilute large volume of urine, diabetes insipidus. There is no history of diabetes mellitus. Which hypothalamic nucleus are most likely damaged? They are simply asking ADH is released from. So maximum ADH is released from, which one? So prooptic and also from paraventricular, both are given. So ADH is mainly by supraoptic, paraventricular mainly for oxytocin. But both are involved in ADH and oxytocin. So answer will be D. Clear? In cholera diarrhea, there is increased activity of which channel is primarily responsible for increased watery intestinal secretion. So when I am discussing in the respiratory physiology, I always discuss about the cystic fibrosis and cholera because the channel is same. Even in the endocrine chapter, whenever we discussed about the CFTR, do you remember CFTR? Cystic fibrosis transmembrane regulator. This I used to discuss in chapter of cystic fibrosis, and there only I used to say it is nothing. It is simply a chloride channel. Chloride channel. So mutation of CFTR in cystic fibrosis is there. We know that. And in cholera, what happened? In cholera also, this is mutated because of, alpha S. Okay, it cannot dissociate. So alpha S keep on activating adenyl cyclase. Adenyl cyclase will activate cyclic AMP. Cyclic AMP will activate protein kinase A. Protein kinase A will activate CFTR. CFTR is a chloride channel. A lot of doctors said that answer was sodium. No, answer is chloride. Okay. And this sodium will follow. Money follows the chloride is followed by sodium and sodium is followed by water, isn't it? So this is causing the secretory intestinal secretion, diarrhea, cholera. So please remember it is the CFTR. Same thing happened in the mutation there in the cystic fibrosis. And if you remember, there was one more question from the pertussis. In cholera and pertussis, in both conditions, cyclic AMP is increasing. But cholera is acting on GS. Pertussis was acting on GI. Cholera causes on switch permanently on. Cholera causes on switch permanently on. And pertussis causes off switch permanently off. But both will increase cyclic AMP. There was some question in medicine, I don't remember, but the same concept is there about the cholera and pertussis. Now, match the following structure with the marking on the image. If you have done the classes, you know I always use the image for that because plenty of time they have asked about the Pacinian causal free nerve ending. Okay, so this time also they have repeated the same thing. You can see the A. A is clear cut free nerve ending. Free nerve ending is for mainly pain and temperature. Pain and temperature, doctor, and you know they are called as TRP receptor. Okay, now B, you can see the B is having a disc. These discs are there, so it will be Merkel disc. Then the C is like an onion Pacinian vibration. So onion shape will be Pacinian. Okay, and the D will be Ruffney ending. So option will be like that. First A. So 1A, 1 will be A, okay. 2 will be D, okay. Then 3 will be, 3 means Pacinium will be C, okay. And fourth, okay. So answer is 1A, 2D, 3C. It was a comparatively easy question. If you remember, Pacinians are onion shaped, okay. So this is it from my side. Thank you. Okay. So after that, again, we will discuss all topics in detail regarding the discussion of the recall question. So this is it for today. Thank you.
and some of you will be watching live and some of you will be seeing this discussion later on. I'm Dr. Sandeep Sharma. I'm the pediatric faculty at DocTutorials for NEET PG, INSET, and FMG exams. And the discussion we are going to make is based upon the questions which have been asked. Now, because the exam has been done only a few hours back, so understandably, we will not have a complete recall. The aim is to understand what mindset examiner is doing, what did you mark, and what are the answers possibly if the option changes in the question paper. So let us start with question number 1. I'll not take much of your time. I will finish in about 10 minutes so that you can, just quickly go through the recall part. Now, question number 1 says, a 3-day-old newborn presents with fever, jaundice, hepatosplenomegaly, and chorioretinitis. He also had leukocytopenia. I have just been told that some thrombocytopenia was also mentioned and hearing loss. The skin lesions are as shown below. What is the most likely diagnosis? Now, if you look at this newborn, the rash that you can see here is the typical blueberry muffin rash. This is the typical blueberry muffin rash that is seen in the child. Now, the differentiation of blueberry muffin rash includes congenital infections like CMV and rubella. It includes neuroblastoma, congenital neuroblastoma. And thirdly, there will be congenital leukemia cutis, which can occur as a complication of conditions like LCH or sometimes leukemia, neonatal or fetal leukemia as well. So D option was not recalled, but among A, B, and C, if you just look at blueberry muffin rash, all the 3 possibilities are there. Now, the first one to be ruled out will be congenital neuroblastoma because there will be some mass, and congenital neuroblastoma will have additional features. Most of these children, when they present, they already have features of some bony metastasis, or they have features like hepatosplenomegaly along with lymphadenopathy, some abdominal mass palpable, and let me tell you, congenital neuroblastoma actually is a very, very rare condition. Plus, hearing loss will not be a feature of these patients. Chorioretinitis will not be a feature of neuroblastoma. So neuroblastoma is ruled out. Now we are stuck with A, CMV, and C, congenital leukemia cutis. Now, if the word periventricular calcification or brain calcification is mentioned along with hearing loss, your answer goes in favor of CMV. If there is no hearing loss and no calcification mentioned, it goes in favor of congenital leukemia cutis. Remember that whenever they make a case scenario of congenital leukemia cutis, they will always mention blast cells. They will say leukocytosis or leukopenia. But, these patients, congenital leukemia cutis, some additional information will be given. Because hearing loss is mentioned, because chorioretinitis is mentioned, and some of the students said, sir, thrombocytopenia was also there and calcification of brain was also there. So my better answer will be congenital CMV. Please be clear, congenital leukemia cutis answer kab hoga if there is no chorioretinitis, no hearing loss, and no calcification of the brain mentioned in the question. So your better answer in this question is A, but if the options change, if the language changes, your answer will also change. So this is a close call. This is not a very easy question. This is a question where you mark and you feel that you are very, very happy solving this. But actually, this is a question where one word can make the answer go in either A direction or in C option. So answer, according to me, it is A. It will Rathod Devraj Singh, I do not know. This is based upon the recall that we have got from the students who have given the exam, right? If it was a different question, you have to see. I've given you the option, the information. Accordingly, your answer will also change. Next question is 6-year-old unvaccinated child. He has fever, sore throat, difficulty swallowing, and grayish-white adherent membrane over the tonsil is present. So this is a patient with diphtheria. Now, diphtheria is caused by Corynebacterium diphtheriae, and these patients, diphtheria acts by producing an exotoxin. This exotoxin causes ADP ribosylation of elongation factor number 2 and causes permanent inhibition of protein synthesis. So the answer to this question is C, inactivation of elongation factor 2. It is integrated between the clinical subjects as well as the microbiology part. Diphtheria had a lot of questions. This is one of the questions which was asked. Then the third question was related to vaccine strain. 6-year-old unvaccinated child, fever, painful swelling in below one cheek, it was mentioned. The other cheek also became swollen. Typical history with mumps. Usually starts as unilateral parotitis, later on goes into bilateral parotitis. Which vaccine strain is used? Jarrell-Lynch strain is the vaccine strain used for creating mumps virus vaccine. Next, we have 4-year-old child has small PDA detected in infancy. It is asymptomatic and has a continuous murmur. What is the appropriate management? Now, here comes the role of concept. PDA, if it occurs in a preterm child and detected within the neonatal period or within the first 6 months, it shows good response to indomethacin. But it is seen that medical closure fails if it persists beyond 1 year or if it is an older child or a term baby. So medical closure at 4 years is definitely not the answer. PDA, if it is open, there is always a possibility of lung overload, pulmonary circulation overload, even if the symptoms may not be there. And there is always a possibility of infective endocarditis later on. So reassurance and follow-up will also not be needed because spontaneous closure of PDA does not occur after 1 to 2 years. So A is ruled out. Surgical closure when symptomatic, you will not wait for symptoms to occur because symptoms will appear when pulmonary hypertension comes in. That is not the answer. Elective surgical repair is your answer. Elective surgical repair means counsel the parents, arrange for the funds, give a date, but tell the parents surgery has to be done. No role of emergency surgery, no role of surgery in a symptomatic state. Plan a surgery in the next few months and give a date and do surgery in the patient. So elective surgical repair is your answer. Elective surgical repair is your answer, right? If you have any doubts, answers will change according to the options given to you, but be very clear, 4-year-old child में medical therapy नहीं देंगे, medical closure नहीं करेंगे, reassurance नहीं करेंगे, emergency surgery नहीं करेंगे. Be very clear about it. So what are we left with? D is your correct answer. Next, there was a question on 2-year-old child who was fed predominantly on rice gruel, that is kanji. Photograph was given similar to this. Bilateral pitting edema was there. There was also a photograph of Shakir tape where 11.2 or 11.3 reading was given according to the recall. What is the most likely diagnosis? Now, whenever MUAC is less than 11.5, it is SAM, severe acute malnutrition, and which is a condition where edematous malnutrition occurs. It is severe acute malnutrition, Kwashiorkor variety. Remember, Kwashiorkor always needs admission. You cannot treat on OPD basis. High protein diet, you don't start immediately. First stabilize the patient, then you go for rehabilitation. And during rehabilitation phase, you give high protein diet. Look at the option. Is it moderate acute malnutrition? No. Carbohydrate deficiency, give high carbohydrate diet. He's already getting carbohydrate. No, that is not the answer. Acute protein deficiency. No, it occurs due to sustained protein deficiency. And you never start immediate protein that can worsen the child. So what is the answer? Severe acute malnutrition, admit the child. All SAM children where there is severe edema or any complication or danger sign or poor appetite have to be admitted in a hospital. Remember, Kwashiorkor child needs admission and you stabilize the child, and then on rehabilitation, you start with high protein diet. So B is your better answer. Next, we go to this question. A child had severe progressive bowing of legs with a positive family history in the brother, and diet is normal. Investigations were given. Calcium and vitamin D were within normal limits. Serum phosphate was low. Renal phosphate absorption was less than 80%. So renal wasting of phosphate and low serum phosphate with a positive family history, this is going in favor of hypophosphatemic rickets. Now you may ask me, sir, VDDR क्यों नहीं है? These patients have low calcium levels, high PTH, and vitamin D levels are variable. Variable means they can be high, they can be low. This is not the scenario, so A is ruled out. Renal tubular acidosis patient, again, will not be presenting like this. These patients will have acidosis mentioned. Some people said, sir, pH bhi diya hua tha, pH normal tha, so renal tubular acidosis does not present like this. And about Fanconi syndrome, again, Fanconi syndrome and RTA have a overlapping picture. So if you are ruling out RTA, this is also ruled out. So hypophosphatemic rickets was the answer. Some of the students said कि sir SAM नहीं था पिछले क्वेश्चन के अंदर. SAM नहीं था, severe malnutrition word होगा. Acute malnutrition and admit the child होगा. If there is a similar thing, that will be your answer. You need to understand, I have not given the exam. You people have given the exam. My purpose of telling you is, if this is the question, this is the answer. You're all doctors. You're not just NEET UG students. You are preparing for NEET PG. As a consultant, as your educator, it is my duty to tell you कि अगर ये question है तो ये answer है. अब क्या था? This is for you to figure out and then see what you marked actually in the exam. Because in exam, one word change, one word added will always change the answer. And there is no way for us to get the absolute correct language used in the question. Moving further, 5-year-old boy was evaluated for poor growth and recurrent episodes of dehydration. Examination revealed a triangular face like this. There was hypokalemic metabolic alkalosis, normal BP, and everything is fitting into a syndrome called as Bartter syndrome. Bartter syndrome. Bartter syndrome. Now, Bartter syndrome के अंदर defect कहाँ होता है? There is always a defect in the thin ascending limb of loop of Henle. This is something we have discussed in the regular videos also in DocTutorials, the nephrology part. You would find that this particular part, you have a sodium potassium 2 chloride transporter which is defective in the ascending limb of loop of Henle, and that is the correct answer. Gittleman syndrome and Liddle syndrome affect the distal parts more. They do not affect the proximal part or the loop of Henle. So D is your correct answer. Then 9-year-old child is evaluated for short seizure. I'm very happy to say this topic I have discussed in my YouTube sessions. The free discussion part, the T&D part, I have taken it already. So I was very happy, and it is actually an easy question also. So I will not take too much of credit for this. It is a very simple topic. There is a child with short stature. Growth hormone is high. IGF-1 is low. Normal to high growth hormone with IGF-1 low means there is a deficiency of growth hormone receptors. And if there is a deficiency of growth hormone receptor, we are dealing with a syndrome called as Laron's syndrome, also called as Laron's dwarfism. Due to deficiency of growth hormone receptor, there will be growth hormone levels which will be increased. In some variants, they can be high normal. High normal means they will be normal, but on the higher end of the normal range. But IGF-1 levels will always be low in the patient. Along with that, these patients will have severe short stature, and these patients will also have facial dysmorphism. So facial dysmorphism like low set ears and flat nasal bridge, all of them can be there. The treatment in these patients will be recombinant IGF-1 hormone injections. They are given subcutaneously in most of these patients. Now, a male child with recurrent joint bleeds was found to have hemophilia. Which other family member will be affected? Hemophilia A and B, both of them show X-linked recessive inheritance. So which member will be affected? X-linked recessive. Indirect question. X-linked recessive follows this type of inheritance pattern. Let us say this is a male child who is suffering. Now see, this is the father, this is the mother. Father and mother are not affected, but mother's brother is affected. Can you see both brothers of mother? That is Mamaji in Hindi. So they are the ones who are affected, and because X-linked recessive inheritance shows the pattern, father cannot transfer the infection, right? A father cannot be father cannot be transferring the infection that easily. Mother is a carrier, and if there is a male child affected, mother is a carrier, and mother's all brothers will also be affected. So you will have mother's brother as the correct answer. If you see with a cool calculated mind, similar scenario I have already discussed in the quick revision program of NEET PG on DocTutorials app. Now you will say, sir, सब कुछ तो डिस्कस किया है, सब फैकल्टी ये कहते हैं. Everything is there in notes and videos. You just need to build the concepts and practice them. Okay. Moving further, there were two more questions. Again, unfortunately, the complete recall is not there. There was a question on VSD with holosystolic murmur and sweating on forehead while feeding, right? This kind of question was there. It was a relatively easy question, I was told. And one question on pediatric arrhythmia with ECG was given because the ECG exact strip is not available in the recall. So it is, I'm unable to tell. If you look at this NEET PG exam, pediatrics was slightly on the tougher side. Systemic pediatrics has slight more weightage, but general pediatrics, malnutrition, short stature are still there. The atypical thing was there was no question on development milestone. There was no question directly asked on cystic fibrosis, no question directly asked on pneumonia this time, which was a kind of disappointing. Neonatology had particular low weightage. But if you actually see, this was a systemic plus general pediatrics based paper. So for future exam, you also need to keep that in mind. One system may totally get blackened out or totally wiped out in the exam. And this finishes our discussion. In case you have any doubts, feel free to reach out to me. I have been told one more question by the students that IMNCI guidelines pe question tha. There was a 6-week child in whom there were pustules mentioned, some fever mentioned, and other features were mentioned. And they were asking about labeling and what next needs to be done. Again, if you have gone through the IMNCI guidelines, you should have been able to solve. But again, the recall is missing. So pediatrics had roughly about 8 to 10 questions, which is the general weightage that we find. In case you find any more questions, detailed recall of this with proper question, proper answer, and proper detailed explanation. We will be coming out shortly on YouTube as well as on YouTube. So thank you so much. Take care and take some rest. You have gone through a big ordeal right now. God bless everyone. All the best for results.